Vinola. I have the privilege of introducing a wonderful academician, a very good friend of mine. I should say a pillar of support in organizing all the events for ADE. He's our web admin. He sets most of the question papers for us, and he steps into anybody's shoes to fill up the space because he can take oral pathology, oral histology, oral anatomy, general pathology. So any class which I really want somebody to take in, I can always fall back at this wonderful academician, a full-time teacher. And I think he would be the best person in this entire platform among all the speakers we have. I know that all the speakers have been handpicked and chosen to give the best to you guys. But this particular person has done both undergraduation and post-graduation, the prestigious MGPGI, that is the Mahatma Gandhi Institute of Postgraduate Institute of Sciences, like Pondicherry. So Government Dental College, Pondicherry. So I only remember that as MGPGI. Sorry for that confusion. But he, if I'm not wrong, in 2004, he was the first rank holder in the Pondicherry state entrance exam or Pondicherry Union Territory entrance exam. And he did both undergraduation and post-graduation in the same college. And from then on, he's been a full-time, wonderful academician, and we can always fall back into him. Over to you, Dr. Prasad. I'm very happy to introduce my good friend. And thank you for accepting. And again, as mentioned, I think the speaker came in at 9:45. And today there is a little bit of delay. I still request all the participants to join in a little bit early because all the speakers have been asked to be ready from 9:40, 9:45. And so we can start on time because 3 hours is not really going to be enough for them to deliver. And Prasad can talk for hours. He can talk for 2 days on oral histology and oral pathology. And we've given him only 3 hours and we have already taken away 10 to 15 minutes of his time. Over to you, Prasad. And thank you so much for accepting this invitation.
Thank you, Sharath, for that wonderful introduction. I think I'll just start with sharing my screen. Yeah, I hope the screen is visible. PowerPoint is visible, right?
Yes, it's visible. It's visible, Prasad.
So, Tamil Nadu State President Dr. Bhaskar and Tamil Nadu State. Yeah, so I'd like to put on record by thanking the IDA State Tamil Nadu branch, Sendamarai Kannan, for organizing this sort of neat preparatory classes for the prospective postgraduate students. And of course, special thanks to Dr. Vinola for being the person who has organized this single-handedly. So I think without much further, I think let us start with the actual topic, that is MCQs for oral pathology. Now, before going into the subject, let me just put forth to you a couple of oral path preparation for this. Let us just see the two important, starting with the questions. Okay, so one thing is like oral pathology and oral medicine, usually it is combined together and it is taken together nearly 10% of the questions that are coming from this particular subject alone, oral path and oral medicine combined together into 4 marks each. It is nearly 100 marks that you can score only from oral pathology and oral medicine. Okay, and another thing that you have to remember is that the questions in the case of oral pathology can be either direct questions. You can have questions in the form of direct facts, like for example, what is the most common odontogenic tumor, or what is the commonest location for this particular malignancy. So that sort of direct questions can be asked. Or you can have questions that are case-based. I think in the recent years, we are seeing that these case-based questions and picture-based questions are becoming more frequent. You will be given a case description and you will be asked to come at a diagnosis or suggest a possible treatment plan for that particular case. Okay, so that is one possibility. Another possibility is you can have picture-based questions. You can be given a radiograph and you can be asked to diagnose what that particular lesion is, or a clinical photograph will be given. What I'm seeing is in the recent few years, these case and picture questions are dominating more when it comes to oral path and medicine. Okay, so you should be prepared to answer such type of question also. Okay, so as mentioned earlier, I think this 3 hours is going to be quite difficult to cover the entire oral pathology subject, but I'll try to do as much justice as possible. I'll try to cover these topics. Okay, starting from developmental disturbance, caries, etc. I'll try to cover some of the more important questions. Okay. My audio. Yeah, am I audible now? Yes, can yeah, okay, fine. Okay, so as usual, like I expect answers in the chat box. Okay, so answer whether it is A, B, C, or D, you can just answer it in the chat box, and let us try to quickly cover as much as possible. Okay, so let us start with the developmental disturbances chapter. Now, starting with something very basic. Now, this is a very important topic, developmental disturbances. You keep getting questions repeatedly. Okay, so union of roots of adjacent teeth through cementum, what is that called as? Yeah, I'm getting lots of answers saying it is A. Yes, exactly. A union of roots of the adjacent teeth, that is called as concrescence. Now, when it comes to this particular question, you should be able to identify all the different developmental disturbances affecting the shape of the teeth. Okay, so you have lots of disturbances: concrescence, gemination, fusion, dilaceration, dense indentate, dense invaginatus. Okay, taurodontism. So there are so many different developmental disturbances affecting the teeth. So you should be able to differentiate one from the other. Okay, so concrescence is when two roots are joined by cementum alone. If you see the other choices in this particular question, fusion refers to uh, the condition where two teeth are joined together by dentin. Okay, dentin will be continuous in the case of fusion of two adjacent teeth. Okay, whereas gemination, as the term indicates, okay, gemini means twinning. Okay, so Gemini, I think all of you must be remembering the sun sign for Gemini. Gemini is stands for twins. Okay, the sun sign is twins. The Gemini picture படத்தோட அந்த இது பார்த்தா கூட உங்களுக்கு தெரியும். Okay, so you have twins who are representing Gemini. Okay, so gemination means one single tooth bud that is dividing into two separate tooth buds, giving rise to two separate teeth. That is gemination. And dilaceration is a condition where you have an abnormal bend in the tooth structure. Okay, due to trauma or any other factors, you will find that there is an abnormal angulation or bend in the tooth anywhere from the root to the crown. Anywhere there can be an abnormal bend, that is called as the dilaceration. Okay, now peg-shaped incisors. Okay, peg-shaped incisors, you must have come across this particular term very frequently. Now this is seen in all of the following conditions except which one? Yes, again, I'm getting lots of answers saying that it is B, rickets. Very good. Rickets is a condition where there is a vitamin D deficiency. Okay, now vitamin D deficiency, it does not directly affect the mineralization of the tooth. Rather, it only results in a delayed eruption. Okay, so tooth eruption slow down agum, but otherwise morphology of the teeth are not affected in the case of vitamin D deficiency rickets. Okay. Now, peg-shaped incisors means, like normally if you see the incisors are having a wide incisor ledge and they are slightly tapering towards the cervical region. Whereas in the case of peg-shaped incisors, you find that they are almost tapering towards the incisal edge. Okay, so this happens in congenital syphilis. You can have this sort of a disturbance in congenital syphilis. You will have it in ectodermal dysplasia, and you will also have it in supernumerary teeth, especially mesiodens. Mesiodens na typically that conical shaped appearance is there. So peg shaped are nothing but the conical shaped teeth that are seen in many of these conditions. What is the reason? If you try to understand, you will find that the incisors are usually developing from different lobes. Okay, you have the different lobes that are fusing together and forming the anterior teeth. Okay, in the case of these disturbances like congenital syphilis or ectodermal dysplasia or supernumerary teeth, what happens is the middle lobe, the lobe that forms the central portion of the incisal anterior part, that becomes disturbed. It does not develop adequately. So mesial and distal surfaces will tend to taper towards the incisal edge, and that results in the peg-shaped incisor or a conical shaped incisor. Okay. Okay. The next question, in erythema migrans, which papillae of the tongue are absent? So you should know for this, what is erythema migrans? So erythema migrans is a condition also referred to as the geographic tongue. Okay, in the answer terinja, I think you will be able to definitely tell which papilla is absent. Okay, so erythema migrans is nothing but another name for geographic tongue. Basically, like many of you have mentioned, it is the filiform papillae that is being absent, that is lost in the case of erythema migrans. Simple to remember, wherever there is a bald tongue appearance, okay, whether it is due to iron deficiency or due to erythema migrans, geographic tongue, in the bald tongue conditions, usually it is the filiform papilla that is lost. Okay, so when there is a loss of papillae, it is usually the filiform papilla that is easily lost. Redness of the tongue, tongueல வந்து red spots இருக்கு, prominent reddish discoloration or red spots of the tongue இருக்கு அப்படின்னு சொன்னா, it is most likely because of fungiform papilla. Because fungiform papilla, it is covered by a non-keratinized epithelium. So blood vessels, அடியில இருக்கிற blood vessels நல்லா prominent தெரியும். So that becomes reddish spot-like appearance can be seen. So in conditions where there is a prominent fungiform papilla, you will find that the tongue is covered by the reddish spots. Okay, so absence of filiform papilla is a characteristic feature of the geographic tongue or the erythema migrans. Okay, now another thing that is very important when it comes to the developmental disturbances are the various syndromes. Okay, நிறைய syndromes இருக்கு. I think I have compiled a list of syndromes towards the end of the session. Probably 2 or 3 slides I have listed out the various syndromes. So probably you can take a screenshot of that later on. So for now, facial edema, cheilitis granulomatosa, and Fisher tongue characterize which syndrome? Yeah, again, many of you have answered. It is nothing but the Melkersson-Rosenthal syndrome, a very typical feature where there is a facial edema. You have cheilitis granulomatosa and Fisher tongue. Okay, so oral manifestation pathina, mostly the Fisher tongue. Fisher tongue means the tongue has lots of deep grooves and fissures. Okay, நிறைய folds இருக்கிற மாதிரி இருக்கும் tongueல. That is a characteristic feature of Melkersson-Rosenthal syndrome. You can also have cheilitis granulomatosa, which is nothing but inflammation of the lips. Okay, cheilitis means inflammation of the lips, and when you see the histopathology, you will find that that inflammation is made up of lots of granulomas. Okay, accumulations of inflammatory cells in the form of granulomas will be seen in the lips. That is called as cheilitis granulomatosa. So cheilitis granulomatosa, Fisher tongue, and facial edema together, they make up this Melkersson-Rosenthal syndrome. Okay, now you should know what is Fraze syndrome. I think all of you must be aware of this particular syndrome, Fraze syndrome, also called as the auriculotemporal syndrome. That is also called as a gustatory sweating. Okay, that is ஏதாவது trauma, parotid region, if there is some trauma or some surgery that is happening, and if the auriculotemporal nerve is damaged, sometimes what happens is this auriculotemporal nerve, instead of innervating the salivary gland in that region, it will rewire and it will start innervating the sweat glands in that particular region. Okay, now the importance is that auriculotemporal nerve carries the parasympathetic sensation. That is, whenever there is a need for salivation, auriculotemporal nerve will carry that stimulus and make the salivary gland secrete the saliva. When this auriculotemporal nerve gets starts innervating the sweat glands, எப்பெல்லாம் salivation தேவையோ அப்பெல்லாம் வந்து you will find that there is a sweating in the cheek region. Okay, so that is the phrase syndrome, also called as the auriculotemporal syndrome or the gustatory sweating syndrome. Okay, Treacher-Collins syndrome, I think again you must have come across this term. This is also called as the mandibulofacial dysostosis, wherein there is some disturbance in the skeletal formation. Okay, fusion of the various sutures of the skeleton is disturbed, and you will also have uh, uh, improper development of the mandible. Okay, so that is the Treacher-Collins syndrome. Down syndrome, I'm sure all of you know, that is trisomy 21. Okay. Okay, now another syndrome which consists of cleft palate, micrognathia, and glossoptosis. What is that syndrome called as? Is it Marfan's, Clausen's, Paget's, or Pierre-Robin syndrome? Yeah, this is again a very typical syndrome, a classic syndrome called as the Pierre-Robin syndrome. Syndrome ke badla, you can also come across this term. Okay, you can also call this as Pierre-Robin anomalad அப்படின்னு சொல்லுவாங்க, இல்ல Pierre-Robin anomaly அப்படின்னு சொல்லுவாங்க. Basically, it is a sequence of events. Okay, most important event in this particular syndrome is small sized mandible. Okay, when the mandible is very small in size, tongue it won't be able to occupy its position within the mandible, so tongue will appear to be projecting outwards. That is called as the glossoptosis. And because the tongue is extending outwards and upwards, the palatal shelves, they won't be able to fuse with each other in a horizontal plane, so there will be a cleft palate. Okay, so micrognathia leading to glossoptosis, leading to cleft palate, that is called as the Pierre-Robin syndrome, a very typical and classic syndrome. Okay, again idla matta syndrome pathina, Marfan syndrome is a skeletal disturbance where you have lots of anomalies. Okay, especially the patient will be very tall, will have hyper flexible joints. Okay, and he'll have this arachnodactyly, that is long spider like fingers. Idella vandu a classic feature of Marfan syndrome. Clausen syndrome, again it is a type of craniosynostosis. Okay, craniosynostosis na, there is a defect in the fusion of the cranial sutures. So Clausen syndrome is a condition where there is a early fusion of the cranial sutures. Adanal there will be a characteristic skeletal defect. Okay, I'm not going to go into the details about all that. Just remember that it is a craniofacial dysostosis or craniosynostosis. That is Clausen syndrome. Paget's disease is a totally different entity. It is a defect where there is an abnormal remodeling of the bone. Okay, so that is called as the Paget's disease. Okay, now coming on to ameloblast. Okay, during the formation of the teeth, ameloblast will be disturbed by high fluoride water content, and that results in a specific type of a enamel hypoplasia. What is that hypoplasia called? Yes, it is called as the mottled enamel, right? Yeah, so mottled enamel is nothing but a specific term for hypoplasia that results from high fluoride content. Okay, fluorosis. Basically it is an enamel hypoplasia. Okay, again if you see enamel hypoplasia, there is a defect in the ameloblast, and that defect in the ameloblast will result in either decreased formation of the enamel, or mineralization of the enamel will be affected, or the maturation of the enamel will be affected. So you have hypoplastic type, hypocalcified type, or a hypomaturative type of enamel hypoplasia. Okay, so that is based on how much of the enamel secreting process is affected. Okay, now you can also classify enamel hypoplasia based on the causes. Okay, you can have enamel hypoplasia due to genetic causes, that is called as the amelogenesis imperfecta. Okay, so amelogenesis imperfecta is nothing but enamel hypoplasia due to some genetic causes. Again, you can have autosomal dominant, autosomal recessive, and all these different variants. Okay, so all that is separate. Now, when it comes to the other category, you can have enamel hypoplasia due to environmental causes also. Okay, there can be so many different environmental factors that can result in enamel hypoplasia. And one of these environmental factors is the excess amount of fluoride in the water, that is fluorosis. Okay, and fluorosis lavara and the enamel hypoplasia is characteristically called as the mottled enamel. Now, if you see, all the other three are also types of enamel defects. Okay, Turner's tooth is nothing but a enamel hypoplasia affecting a single tooth. Okay, just a single tooth is affected. இதுக்கு என்ன ரீசன் பார்த்தீங்கன்னா யூஸ்வலா the overlying deciduous tooth வந்து there will be some infection in the deciduous tooth. There will be a caries or some sort of a periapical infection in the deciduous tooth, and that periapical infection will affect the ameloblast of the underlying permanent tooth. Okay, so அந்த மாதிரி ஒரு single toothல மட்டும் enamel hypoplasia இருந்துச்சுன்னா due to the predecessor, due to the deciduous tooth that is overlaying that particular type of enamel hypoplasia is called as a Turner's tooth. Hutchinson's tooth, again, I think all of you know, it is seen in syphilis. Okay, congenital syphilis, you can have Hutchinson's tooth. And Moon's molars, again, it is a feature of congenital syphilis. Both Hutchinson's tooth and Moon's molars are a type of defect in the tooth morphogenesis. Okay. Okay, now this I have just now answered this question. A permanent tooth with local hypoplastic deformity in the crown. It is also called as the, yes, yeah, I have answered this question just now, and all of you are answering the same thing. Yeah, it is also called as a Turner's tooth. So I think I have already explained that permanent tooth affect our Turner's hypoplasia is usually going to affect only the permanent tooth, not the deciduous tooth. Cause pathina deciduous tooth la there will be a dental caries, a deep dental caries with periapical infection, and that will affect the underlying permanent tooth. And if you see, this particular Turner's tooth is very common in the case of mandibular premolars, because the deciduous mandibular first and second molars are having a very high incidence of dental caries. You find that the permanent mandibular first and second premolars are very commonly affected by the Turner's hypoplasia. Okay, now taurodontism is also another developmental disturbance of the tooth. It refers to the disturbance affecting the shape of the tooth. You will find that in taurodontism, the tooth is having a very large trunk. Okay, the bifurcation on the bifurcation of the root is at a very low level in the case of taurodontism. So this resembles the tooth of cattle. The bulls, cows lam pathina இந்த மாதிரி tooth இருக்கும். That is why it is called as a bull teeth. Okay, now again, this has a reference to the sun sign. Taurus sun sign pathina, bull da on the Taurus oda sun sign. Okay, so taurodontism means bull like tooth, wherein there is a defect in the level of the furcation of the roots. Okay, enameloma is nothing but the enamel pearl. The usual enamel is seen in the crown, but sometimes you can have small spots of enamel that can be seen near the furcation area, especially of the molars. So that sort of small enamel pearls, that is also called as an enameloma. Ghost teeth, I think we'll discuss later in a separate question. Okay, now developmental disturbance, there is one other category, that is the cyst. Okay, you have various developmental cysts. So when it comes to nasoalveolar cyst, which is the right option? Now in the very question, you have to go through all the choices and try to understand what they are trying to say, and then you have to pick out the correct choice. Okay, now we are talking about the nasoalveolar cyst. First, nasoalveolar cyst na enna theriyum. It is also called as the this nasoalveolar cyst. Okay, I think I have revealed the answer already. Okay, this nasoalveolar cyst is also called as the Klestad cyst. Okay, it is also called as a Klestad cyst, or also called as the nasolabial cyst. Okay, now basically nasolabial cyst is a very appropriate term. It clearly tells that it is a soft tissue cyst. Okay, so enna aguna in the mari nasolabial fold region la within the soft tissue there will be a cyst formation. Yen varduna, the epithelium that is entrapped when the medial nasal process and the maxillary process will fuse to form the lip. That particular region la epithelium entrapped and the epithelium, if it gives rise to a cyst, it is called as a nasolabial cyst. Because it is a soft tissue cyst, radiolucency is not a feature. Okay, it is not seen within the bone, so it is not a feature of a bone radiograph. Okay, so radiograph edukumbodhu usually you won't be able to find any changes in the case of a nasoalveolar cyst or a nasolabial cyst or Klestad cyst. Okay, so the nearest answer is sometimes you can have an erosion of the base above the lateral incisor and canine teeth. Okay, so canine and lateral incisor nadula, that bone will show slight erosion. Okay, and that might be visible in the radiograph. Usually it is not seen in the radiograph. Intraoperative paakumbodhu, you will find that only that surface is slightly scooped out. Okay, so that is a typical feature of nasoalveolar cyst. Okay. Now, ghost teeth. I think just now we saw in another option. Ghost teeth is seen in which of the following conditions? Yeah, again, this is a very direct question. Ghost teeth is a typical feature of something called as a regional odontodysplasia. Okay. Now, yeah, the ghost teeth in sonanga bin terinja, you will be able to answer. Okay. Now, I think you must have seen old movies, lots of old movies, ghost movies. Adlam pathina, ghost will be shown as a or transparent white floating material mari kaatuvanga. Okay, or transparent whitish floating in air and the mari or appearance தான் வந்து ghost generally கொடுப்பாங்க. Okay. Now, in the case of regional odontodysplasia, when you take a radiograph, you will have similar feature. Okay. In the case regional odontodysplasia, enna aguna, basically there is some developmental defect that affects both the enamel formation as well as the dentin formation. So enamelum radio opaque thicka radio opaque irukadu. Dentinum it will not be so radio opaque. So அந்த இடத்துல radiograph எடுத்து பார்க்கும்போது you will find that it is almost just a hazy or faint white shadow மட்டும்தான் tooth பதிலா தெரியும். That is why it is called as a ghost teeth, a typical feature of regional odontodysplasia. Okay. Now, densin dente is totally different. Okay, that is basically a tooth within a tooth appearance. So, due to invagination of the ameloblast, you will have a tooth within a tooth appearance. That is the dentin dente. Dentin dysplasia is totally different. Okay, you have a defect in the dentin formation, and you have two basic types. You have the radicular dentin dysplasia and coronal dentin dysplasia, and aduketa mari you can have radiological pictures that are varying also. In dentin dysplasia in general, if you see, there are high chances of having periapical radiolucencies. Okay, pulp chamber pathina thin crescent shaped pulp chamber irukum. Okay, in the case of dentin dysplasia, you can have thin crescent shaped pulp chambers, or sometimes you will have what is called as the thistle tube pulp chambers. Okay, thistle tube mari pulp chambers irukum. Okay, so those are the features of dentin dysplasia. Okay. Now, which of the following lesions does not give blood on aspiration? Okay, again, this is a mixture of different topics. Okay, it is not exclusively developmental disturbance. Either on the you have to be ready for such questions also. Okay, you can have over feature padichirpinga, but you should be able to correlate all those features together and try to arrive at an answer. Now, which of the following lesion does not do blood on aspiration? I'm sure all of you know what is aspiration, right? So lesion you just put a needle and syringe and try to suck out the contents of that particular lesion. So that is aspiration. Okay. Now, when you do aspiration in the case of hemangioma, because it is made up of lots of blood vessels, definitely you will have blood. Okay. What about the static bone cyst? I say a couple of you have given the answer that it is static bone cyst. Correct. Okay. So static bone cyst na enna theriyum. Okay. Static bone cyst is also called as the developmental lingual salivary gland depression. Okay. So basically, salivary gland sometimes it will get entrapped, or sometimes it will cause a depression in the lingual aspect of the mandible. And when you take a radiograph, it will appear like a bone cyst. Okay. And that or a syringe if you try to aspirate, you will be able to get only salivary secretions. You won't get blood in the case of static bone cyst. Okay. So hemangioma I have already told, because it is made up of blood vessels, definitely you will get blood on aspiration. Central giant cell granuloma is a condition where you have lots of giant cells, and poured away you will have lots of capillary proliferation also. So again, there will be lots of blood that you can aspirate. An aneurysmal bone cyst is basically a large aneurysm within the bone. Definitely you will have blood on aspiration. Okay. Most common missing tooth in the permanent dentition. Now, first thing we'll be looking for this is third molar. Okay. Unfortunately, third molar is the choice. So after the third molars, which is the most common missing tooth in the permanent dentition? Yeah, I can see either mandibular second premolar or maxillary canine or the options that I am getting. The correct choice would be the mandibular second premolar. Okay, so always it is the third molars, maxillary or mandibular third molars, that is the most common missing tooth. அதுக்கப்புறம் பார்த்தீங்கன்னா it is going to be the mandibular second premolar. Okay, after the mandibular second premolar, the next most common missing tooth is the maxillary lateral incisor, and then you have the maxillary second premolars that are commonly missing. So this is the sequence of the commonly missing tooth: third molars, mandibular second premolar, maxillary lateral incisor, then maxillary second premolars. Okay, and in general, or a general rule என்னன்னா, molars which is the most common, the distal most molar, that is the third molar, is going to be the commonly missing tooth. Premolars பொறுத்த வரைக்கும் first and second premolar, second premolar is the distal most tooth, so second premolar is always the most commonly missing tooth rather than the first premolar. Same thing for incisor also. When it comes to central or lateral incisor, the lateral incisor is going to be the most commonly missing tooth rather than the central incisor. Okay. Now, delayed eruption of at least a part of the dentition is a recognized feature of all of the following, except what? எந்த கண்டிஷன்ல delayed eruption இருக்காது? Okay, so always pay attention to the negative terms in the question. Okay, stemல வந்து not commonly, இல்ல வந்து except, all are true except, இல்ல which is false, அந்த மாதிரி negative questions இருக்கிறது you have to definitely pay attention to. Okay. Now, இதுல வந்து பாத்தீங்கன்னா, okay, again, so many of you are answering correct answer, that is congenital hyperthyroidism. Yeah, that is the correct answer. Rickets, I mentioned already, vitamin D deficiency is associated with delayed eruption. Okay, congenital hyperthyroidism. Hyperthyroidism oda property என்னன்னா, it will accelerate all the bodily processes. Okay, bodily physiological process எல்லாமே வந்து hyperthyroidismல accelerate ஆகும். The BMI is increased. Okay, similarly you will find that metabolism is increased, all the timelines are going to be accelerated. So eruption is going to be premature in the case of hyperthyroidism. இதோட opposite hypothyroidismல பாத்தீங்கன்னா you will definitely have a delayed eruption. Okay, now what about the other two choices, cleidocranial dysplasia and cherubism? These are not directly related to the eruption as such, but இந்த ரெண்டு கண்டிஷனும் பாத்தீங்கன்னா both are associated with multiple supernumerary teeth. Okay, whenever there is multiple supernumerary teeth, definitely there will be impaction and delayed eruption of at least few of the teeth. Okay, so that is why cleidocranial dysplasia and cherubism are also associated with delayed eruption of at least a few teeth in the dentition. Okay. Okay. What are Epstein's pearls? I think again another direct fact-based question. Epstein's pearls are nothing but cysts that are arising from which of these? Is it from the squamous tissue of the mucosa, from the connective tissue of the mucosa, rest of the molasses, or dental lamina? No, I think many of you are confused about this particular entity. Okay, I'm getting the answer that it is from the rest of molasses. Okay, Epstein's pearls are basically dental lamina cysts of the newborn. Okay, so dental lamina larundu you can have cysts that are seen along the midline of the hard and soft palate, that is called as the Epstein's pearls. Okay, இதே மாதிரி dental lamina la irundhu arise ஆற cysts sometimes can be seen on the what to say, the alveolar ridges in the newborn, that is called as the Bond's nodule. Okay, so Bond's nodules, Epstein's pearls, these are basically cysts arising from the dental lamina. Okay, they are especially seen in newborn children. So either you just have to memorize. Okay, Epstein pearls, Bond's nodules seen in the newborn arising from the dental lamina. Epstein's pearls are seen in the midline along the hard palate and soft palate. Bond's nodules are seen either on the alveolar ridges or in the junction of the hard and soft palate on the lateral aspect. You can have the Bond's nodules. Okay. Okay, now this is another confusing question because பழைய புக்ல பாத்தீங்கன்னா வேற மாதிரி கொடுத்திருப்பாங்க, புது புக்ல வேற மாதிரி கொடுத்திருப்பாங்க. Shell teeth are more common in which variant of dentinogenesis imperfecta? Okay, now you should know what are the different types of dentinogenesis imperfecta. Okay, now I am sure most of you must have read from the newer textbooks. Okay, according to the newer textbooks, dentinogenesis imperfecta is only of two types, type 1 and type 2. Okay, இதுவே பழைய எடிஷன், ஓகே ஏர்லி 2000s இல்ல 1990sல இருக்கிற புக்ஸை பார்த்தீங்கன்னா dentinogenesis imperfecta will be described as three types. Okay, type 1, type 2, type 3 ன்னு சொல்லுவாங்க. Type 1 is dentinogenesis imperfecta without osteogenesis imperfecta. Type 2 is dentinogenesis imperfecta with osteogenesis imperfecta. Sorry, type 1 is with osteogenesis, type 2 is without osteogenesis, and type 3 is the Brandywine type of dentinogenesis imperfecta ன்னு சொல்லுவாங்க. Okay, so that will be in the older textbooks. Now current textbooks study, you have only two types, type 1 and type 2. Shell teeth are seen in the Brandywine type of the dentinogenesis imperfecta, which is type 2. Okay, so don't make a mistake. This is a confusing question. When you have a question like this, always go with the newer entities. Okay, newer classifications are always going to be much more accepted. So பழைய bookல type 3 கொடுத்திருக்காங்கங்கிறது it won't be justifiable. Okay, so as of now, if you have an idea that shell teeth or Brandywine type of dentinogenesis imperfecta is type 3 அப்படிங்கிற ஒரு ஐடியா உங்க மைண்ட்ல இருக்குன்னா, change it, make that it is type 2 dentinogenesis imperfecta. Okay, there is no type 3. Type 1 is dentinogenesis imperfecta without osteogenesis imperfecta. Type 2 is the Brandywine type of dentinogenesis imperfecta, where you have a very thin enamel and dentin. Okay, that is called as a shell teeth. Okay, why it is called shell teeth is because enamel and dentin are very thin and it is covering a very large pulp chamber. So பெரிய pulp chamber க்கு வெளியில ஒரு thin shell மாதிரி இருக்கறனால you call it as shell teeth. Okay, now talon's cusp, again a developmental disturbance affecting the shape of the tooth. Okay, now this is characteristic of which syndrome? Is it seen in Edwards syndrome, Klinefelter's, Rubinstein-Taybi, or Down syndrome? So talon's cusp is a feature of Rubinstein-Taybi syndrome. Okay, so talon's cusp na enna pathina cingulum region la you'll have a small projection. Okay, so in the case of incisors, let us say the mandibular or maxillary incisors, cingulum region la you'll have a very small cusp. Okay, a very thin or a very small cusp that is seen arising from the cingulum that resembles the claws of a eagle. That is why it is called as a talon. Okay, so this is called as a talon's cusp, very commonly seen in association with this particular syndrome called Rubinstein-Taybi syndrome. Rubinstein-Taybi syndrome or other features enangarthu definitely not necessary from your exam point of view. Just remember that it is associated with talon's cusp. Klinefelter syndrome could associated with it is the taurodontism. I see many of you choosing Klinefelter syndrome. Klinefelter syndrome is associated with taurodontism. Okay. Now, which of the following dentition shows the highest frequency of supernumerary teeth? Okay, you know supernumerary teeth means more amount of teeth in addition to normal. Okay, so normal permanent dentition la 32 teeth na 33, 36, 40 and the number of teeth increase arda and we call it as supernumerary teeth. In which type of dentition you find it very commonly? Again, many right answers. It is very commonly seen in maxillary permanent dentition. Commonest supernumerary tooth enna, it is the mesiodens. Okay, so between the two maxillary central incisors or sometimes just behind the two maxillary central incisors you can have conical shaped teeth, that is called as a mesiodens, one of the commonest types of the supernumerary teeth. Okay, brittle bone syndrome. What is the cause for this brittle bone syndrome? இதுனா என்னன்னு தெரியணும். brittle bone syndrome என்னன்னு தெரியணும். Basically it is the other name for osteogenesis imperfecta. So if you know that answer, you will be able to choose the correct choice. So osteogenesis imperfecta is basically because of improper synthesis of pro-collagen. Okay, collagen formation defect will be there in the case of osteogenesis imperfecta. Okay, so you find that osteogenesis imperfecta is mainly due to defect in two genes, COL1A1 and COL1A2 gene, Basically, these are the genes that will help in the formation of the collagen, especially the type 1 collagen. And in this particular condition, you will have brittle bones, blue sclera, and then you will also have other complications like dental problems, hearing loss, etc. Okay. Osteopetrosis, I think we'll discuss again later, also called as the marble bone disease or Albert-Schonberg disease. We'll be seeing that in a separate question. Okay, so that is about the developmental disturbance. Next, going on to dental caries, again, just a few questions. I'm sure most of you will be well versed with dental caries. Okay, so according to Miller, which of these acids is responsible for the lesions of dental caries? Very straightforward question. I think all of you should be able to give the correct answer for this. Yes, it is always the lactic acid. Okay, so according to Miller's acidogenic theory or a basic concept and the carbohydrates in the diet will be used up by the microorganisms and they will produce a lactic acid. Okay, so this is just a very short schematic representation of the dental caries etiology. So according to that, all the carbohydrates that are seen in the diet, they will be taken up by the microflora and the microorganisms will produce the lactic acid and they will also produce the dextran from these carbohydrates. Dextran will form a part of the plaque that will help to keep the lactic acid on top of the tooth surface, and that lactic acid will result in the decalcification and demineralization of the enamel. Okay. Now again, another very direct and simple, straightforward question. Bacteria responsible for initiation of caries. These are questions which you should not make any mistake at all. Definitely correct answer கொடுத்து 4 marks எடுத்துட்டே போகணும் இதெல்லாம். Yes, again I'm seeing all correct answers. Most often implicated for initiation of caries is Streptococcus mutans. Okay. இதில் மற்ற organisms, Actinomyces, Lactobacillus, Streptococcus viridans, they are also implicated in dental caries. You should know exactly where they are involved. Actinomyces, especially in root caries, you have Actinomyces organisms. Lactobacillus is also called as the pioneer bacteria. Dentinal caries la pathina earliest penetrating microorganisms that are seen in the deepest parts of the dentinal caries are called as the pioneer bacteria and they are usually the lactobacilli. Okay, so have a very brief summary about all the organisms, microorganisms that are involved in caries. ஒவ்வொரு ஆர்கானிசம்க்கும் என்ன ரோல் அப்படிங்கிறது ஒரு brief summary மாதிரி படிச்சு வச்சுக்கோங்க. That is going to be useful for your exam. Okay. Dental plaque contains all of the following except microorganism, mucin, exudate or desquamated epithelial cell. இதில் எது வந்து dental plaqueல இருக்காது? Yeah, I think I'm getting different answers. Microorganisms, all of you are agreeing that it is seen in dental plaque. Whether it is B, C or D, I'm getting different answers from different candidates. Okay. Now, always plaque will contain microorganisms, mucin and desquamated epithelial cells will also be a component of the dental plaque. What is not seen in the dental plaque is the exudate. Exudate kum dental plaque kum direct relationship kedayadu. Okay, exudate is basically a result of inflammation. Okay, inflammation la when the fluid is secreted or when the fluid gets accumulated in one particular region, that is usually called as the exudate, an inflammatory fluid. Okay, that has very little role in dental plaque. So usually dental plaque is composed of the bacteria. You have the salivary proteins. Mucins are nothing but the salivary proteins. Okay, you have the lipids, carbohydrates, that is usually the dextrans. Okay, and then you also have inorganic ions like calcium and phosphate. Okay, the composition என்னன்னு பாத்தீங்கன்னா bacterial and salivary proteins will form the major component. Almost 50% will be the bacteria and the salivary proteins. 25% will be made up of by the carbohydrates and lipids, and around 10% will be made up of by the inorganic ions. Okay. Okay. Now, which theory of dental caries proposes that organic elements are the initial pathway for microorganisms? So, various theories of dental caries. Again, you should be aware of at least the various theories என்னென்ன நேம்ஸ்னு தெரியணும், அதோட பேசிக் premise என்ன அப்படிங்கிறது you should be aware of. Okay, so very commonly we discuss the Miller's osteogenic theory, then you have the proteolysis theory and the proteolysis chelation theory. Okay, now according to the proteolytic theory, they say that the organic pathway of the teeth, they form the path through which the microorganisms involved. Okay, so Miller's osteogenic theory, I'm sure all of you already know. Okay, we already saw that schematic diagram also. Microorganism will act on the dietary carbohydrate, will produce the acid, and the dextran that is produced by the microorganism will form the plaque. That plaque will make sure that the acid is held on top of the tooth surface, and the tooth surface will undergo demineralization. That is the Miller's osteogenic theory, which is the most accepted theory. Okay, proteolysis theory badi enna aguna, they say that microorganisms invade the tooth through the organic components. Okay, the organic components enna nu kettingna, it is usually the enamel lamella. Okay, if you remember oral histology, enamel lamella is a hypomineralized structure of the enamel extending from the surface of the enamel. So through this enamel lamella, the microorganisms will invade the tooth. They will first disintegrate the protein components, and then the decalcification starts. That is the concept behind the proteolysis theory. The third common theory is the proteolysis chelation theory, which says that both components, that is demineralization and protein denaturation, both happen side by side. Okay, so according to the proteolysis chelation theory, proteins on the disintegrate agumbodhu, you will have certain components that are formed, and these components, they will act as chelators. Chelators means they will bind with the inorganic ions and form large insoluble molecules. Okay, so proteolysis chelation theory body, proteolysis happens and produces certain components which will chelate with the inorganic component of the enamel, and so both protein denaturation and decalcification of enamel will happen side by side in the proteolysis chelation theory. Okay, so மூணு theories பேரு தெரிஞ்சுக்கோங்க, understand the basic premise of all the three theories. Again, it is going to be useful for answering questions. Okay, now one other thing we have to remember when it comes to dental caries is நிறைய classifications of caries இருக்கு. So you should know the different types of classifications, and you should know what are examples of some of these types of classifications. Okay, so nursing bottle caries is a type of the, yeah, I'm getting all our answers C. That is true. Okay, it is a basically a type of a rampant caries. Rampant caries means when the caries is spreading very fast. Okay, so one type of this rampant caries is the nursing bottle caries. Again, I'm sure all of you know what is nursing bottle caries. One unique feature of nursing bottle caries is usually the mandibular incisors are usually not affected in the case of nursing bottle caries, because the tongue will cover the mandibular incisors. So the mandibular incisors are usually not affected by the nursing bottle caries. Okay, acute caries, I'm sure all of you know. Okay, caries that is progressing rapidly in a very short duration, that is the acute caries. Chronic caries na caries that is progressing in a very slow manner, that is the chronic caries. Recurrent caries again refers to caries that has occurred after you have treated the primary lesion. Okay, so ஏதாவது ஒரு ரெஸ்ட்ரேஷன் கொடுத்ததுக்கு அப்புறம் ரெஸ்ட்ரேஷன் மார்ஜின்ஸ்லயோ இல்ல ரெஸ்ட்ரேஷனுக்கு அடியில if you get a caries, new caries lesion, that is called as a recurrent caries. And arrested caries is a type of caries where you have chronic or acute caries on the sudden it will become a chronic lesion and then it will stop progressing beyond a point. Okay, now why this happens is usually caries if for it to progress there should be colonization by the microorganisms. Carbohydrates or food should get entrapped within that carious cavity so that it provides the nutrition to the microorganisms. Sometimes due to various reasons like மேல இருக்கிற enamel chip of eye cavity becomes open and self cleansing, or sometimes ஒரு proximal caries இருக்கு, அது adjacent tooth வந்து remove பண்ணனால that proximal caries becomes accessible for tooth brushing and cleaning. அந்த மாதிரி கண்டிஷன்ஸ்ல caries progression will stop, and that is called as arrested caries. Now one of the important features of arrested caries is what is called as the hibernation of dentin. Okay, so this again you can have questions on this hibernation of the dentin again. That is due to the soft pressure on the carious cavity, the dentin will become smoothened out and become polished and shiny in appearance. That is called as hibernation of dentin. And when you remove that, you will be able to peel this hibernation of dentin. That hibernated dentin can be peeled off in layer by layer. Okay, so that is a feature of this arrested caries. Okay. Now again, histopathology of caries quite important. Microscopic appearance, NNS zones, enamel caries, dentin caries, NNS zones. You have to have an idea. So of all the zones that are present in enamel caries, which is not always present. Now, if you see this in the 4 zone, normally you will find it in enamel caries. Enamel caries has 4 zones. You have the translucent zone, dark zone, body of the lesion, and the surface zone. Okay. So deepest will be the translucent zone. Adukku mela dark zone, adukku mela body, adukku mela surface of the enamel caries. So which is not always present. Translucent zone is not always present. Okay, I think some of you have answered correctly. The translucent zone is not always present. Okay, now suppose you see the enamel caries. Okay, you will have a thin translucent zone in the deepest region. Adukku mele you will have a dark zone. Okay, adukku mele you will have the body of the lesion, and then you have the surface of the enamel caries. Okay, now this translucent zone is not always present. Okay, so it is also called as a negative zone. So translucent zone is also called as a negative zone because it is not always present. Okay, dark zone is always present, so it is also called as the positive zone. The body of the lesion the maximum affected by caries that will have the largest cavitations. The pores will be very large in the case of the body of the lesion. Okay, so enamel caries remember the 4 zones: translucent, dark, body of the lesion, and surface. Translucent zone is not always present, so it's also called as negative zone. Dark zone is always present, so it's also called as positive zone. Body of the lesion has the largest pore volume. Surface of the lesion is the region where there is remineralization that is happening. Okay, so it is the remineralizing zone. Okay, now similarly, dentinal caries. Which is the earliest histological evidence of dentinal caries? Okay. Now, in other words, okay, earliest histological evidence, in other words, you can also ask this as which is the deepest zone of dental caries. So if you can correlate this, okay, deepest region will be the earliest change. Okay, adukku mela irukadla vandu lesions that are for a longer time. The deepest portion is the newest portion of the caries. So which is the deepest zone of the dentinal caries? That is the other interpretation of this particular question. Okay, so abdi pathina answer is very straightforward. It is the fatty degeneration of the odontoblastic process. Okay, so you have 5 zones in dentinal caries: zone of fatty degeneration, then zone of dentinal sclerosis, decalcified dentin, bacterial invasion, and decomposed dentin. Okay, so again from deepest to most superficial. Deepest is fatty degeneration, then you have the sclerosis, decalcified dentin, bacterial invasion, and then you have the decomposed dentin. Okay, these are other terms on the normal dentin, subtransparent, transparent, turbid, and infected dentin. Okay, so what is another important point in this particular dentin caries is that always these 2 zones, turbid dentinu, infected dentinu, always have to be removed to prevent recurrent caries. Okay, so during cavity preparation, you have to make sure that the zone of bacterial invasion and the zone of decomposed dentin is completely removed. மீதி 3 layers, transparent dentin, subtransparent dentin, and fatty degeneration, இதெல்லாம் அப்படியே இருந்தா கூட, if you seal the cavity completely, there won't be any further progression of the carious lesion. Okay, so that is something that you have to always remember. Turbid dentin and infected dentin always have to be completely removed. Okay, initiation of dental caries depends on which of these factors? I think this we have already discussed in a different way in the earlier question. Dental caries initiate aganuna, what is important? Large amount of acid form aganuma, illa availability of carbohydrate adhigama irukanuma, or is it the viscosity of saliva that is important, or is it the localization of acid over the tooth surface that is important? Yeah, even though all the different features are important, the localization of the acid on the tooth surface is going to be the single most important factor that determines whether there is a caries lesion or not. Okay. Carbohydrate available irundum, microorganisms irundum. If there is no plaque, then you'll find that whatever acid that is produced, that is going to be easily washed away by the saliva. Even if it is a viscous saliva, that can neutralize the acid that is being formed by the microorganism. Okay. So the microorganism formed பண்ற acid வந்து it should be in contact with the tooth surface and it should be protected from removal. So that protection is being carried out by the plaque. Okay, so that is why we focus on plaque removal for prevention of caries. Okay. Okay, now the Stefan's curve, I'm sure all of you must have seen the Stefan's curve. Stefan's curve எந்த ரெண்டு factors வந்து important பார்க்கணும், or which factor is plotted for caries incidence and sugar intake? Straightforward question. I think nothing to be confused about this question. Stefan's curve, you have an x-axis and a y-axis. Okay, so one axis வந்து we see about the sugar intake, quantity of sugar intake. Okay, and the sugar intake கூட எதை வந்து correlate பண்றோம்னு பார்த்தா, it is the pH of plaque. Okay, so what we do is we plot on the x-axis the sucrose intake. Okay, the time that has elapsed after the sucrose intake, and then on the y-axis we plot the pH of the plaque. Okay, so according to the Stefan's curve, this pH 5.5 is the critical pH. pH 5.5 க்கு கீழே போச்சுனா, you will find that decalcification of enamel happens. So in the below 5.5 pH வந்து, the tooth should not be below this 5.5 pH for a very long time. Within a short period, it has to go back to greater than 5.5. Otherwise, there will be decalcification of the tooth. Okay. So Stefan's curve, mostly they are concerned about the pH of the plaque in relation to the time elapsed after a sucrose intake. Okay. So that is about the dental caries also. I think a couple of minutes break we can take. Okay, just 2 minutes. If you want, you can have water or tea or something like that. Join me in 2 minutes. I'll be online only. Just take a 2 minutes break and then we'll continue from pulp and periapical disturbances. Okay.
Abhinav. Abhinav.
Okay. So let us again continue with the pulp and periapical diseases. Okay. So I think we'll have to go a little more faster. So let me try to just rush through without making it very difficult to follow also. Okay, now starting with the pulp and periapical diseases chapter. Now in the particular chapter, some of the different types of pulpitis you should be aware of. What are the different types of pulpitis? You should be also aware of the different features, clinical features, especially of pulpitis. That is going to be quite important in pulpitis. Okay. And then lastly, about the periapical infections, periapical lesions, periapical cyst, granuloma, abscess, இதுக்கெல்லாம் differentiating feature என்ன அப்படிங்கிறதும் you should be aware of. Okay, starting with a very basic question, which is again a fact-based question. Phenomenon by which bacteria circulating in blood accumulate at the site of pulpal inflammation. What is the name given to this type of pulpitis? Any answers? Okay. Yeah, I'm getting an answer. Either it is retrograde pulpitis or anachoretic pulpitis. This is a very peculiar feature. So this is basically what is called as anachoresis or anachoretic pulpitis. Now, anachoresis, that term anachoresis, what does it mean is that usually whenever there is an inflammation, bacteria will have a tendency to get accumulated in that particular site of inflammation. Okay, the pulpitis mattum kedaiyadu. Generally, wherever in the body, wherever there is an inflammation, bacteria have a affinity to get accumulated in that particular site of inflammation. Okay, so that particular property is called as anachoresis. When it happens within the pulp, we call it as a anachoretic pulpitis. So pulpal inflammation due to some other reason irundirkalam, and when that particular inflammation attracts some microorganisms from the blood to get accumulated within the pulp, we call it as anachoretic pulpitis. Retrograde pulpitis is different. Retrograde pulpitis you have usually a periodontal infection and a periapical infection, and from that periapical infection the pulp will start getting infected. That is a retrograde pulpitis, which is related to an endoperial lesion. Okay, so that is totally different entity. Now this is very important, I think, from your clinical point of view. If you are practicing clinician, I think you will be able to answer this very easily. Pain which increases on lying down is a characteristic feature of which type of pulpitis? Focal reversible, acute, chronic hyperplastica, chronic pulpitis. All are right answers. It is a very typical feature of acute pulpitis. Okay, pain on lying down or pain on bending down. Basically, when there is an increased intrapulpal pressure, there will be a severe pain. Patient won't be able to lie down and sleep at all. Patient will come and tell you that I had to sit and sleep. I could not lie down and sleep. Okay, that is a very typical feature of a acute pulpitis. Focal reversible pulpitis clinical feature, usually you have a very short duration of pain or sensitivity when there is a temperature change, taking in of cold or hot food substances, a very short duration of pain. This is a feature of focal reversible pulpitis. Chronic hyperplastic pulpitis is totally different, also called as a pulp polyp. You will have a growth that is arising from the pulp chamber. That is a chronic hyperplastic pulpitis. The chronic pulpitis usually is just symptom free. Okay, it does not have much of a symptoms when it comes to the chronic pulpitis. Okay, chronic hyperplastic pulpitis, just now we saw it is also called as the pulp polyp, which is not a feature that is associated with the pulp polyp. Open carious lesion occurs in children and young adults, occurs in people with high tissue resistance, occurs around the margin of a restoration, which is not associated with pulp polyp. Yeah, exactly. It does not occur around the margins of a restoration. Okay. Pulp polyp basic feature there is a very large open carious restoration. Okay, sorry, carious lesion. Okay. Now, usually pulpitis has a tendency to undergo necrosis only. Okay, that is because pulp is a very small chamber that is surrounded on all sides by the dentin. So usually pulpitis and the swelling fluid accumulation there is no space for the pulp tissue to expand. So pulp will undergo necrosis. But suppose there is a large open carious lesion and the pulp is communicating with the oral cavity through a large open carious lesion, pulp doesn't have to undergo necrosis. Instead, it will show a proliferative response. Okay, so open carious lesion is a typical feature of pulp polyp. Another two features is that it occurs in children and young adults. Basically, people with high tissue resistance, they show a proliferative response rather than a degenerative response. Okay, so these three features are very typical of a pulp polyp. Okay, all of the following except which occur as a sequelae to pulpitis. Okay, pulpitis which of these lesions does not arise from a pulpitis? Is it a lateral periodontal cyst, periapical granuloma, apical periodontal cyst, or a periapical abscess? Which does not come from a pulpitis? Again, right answers, all of you. It arises from the, lateral periodontal cyst does not follow a pulpitis. ஏன்னு பார்த்தீங்கன்னா lateral periodontal cyst is basically a developmental cyst of odontogenic origin. It is a odontogenic cyst. It does not have a pulpitis as a triggering cause. Okay. The other lesions, periapical granuloma, apical periodontal cyst, all this can occur as a sequelae of pulpitis. So basically this chart, okay, Schaefer's path, you must have come across this chart, sequelae of dental caries. Very important. What are the different possibilities that can happen after dental caries? Okay. So in short, enamel caries can lead to dental caries, to pulpitis. Pulpitis, it can progress to the periodontitis, apical periodontitis, which can be either acute or chronic. If it is acute, it can result in periapical abscess, which can again further lead to the osteomyelitis. Okay. If there is a chronic apical periodontitis, it's also called as a periapical granuloma. That can again lead to either osteomyelitis or it can result in a periapical cyst. Osteomyelitis can result in periosteoitis and then a cellulitis and an abscess, that is a space infection, another spreading type of infection. So the sequelae of dental caries is a chart that is given in Schaefer's textbook. So please go through this sequelae of dental caries also. Okay. Now periapical granuloma, periapical granuloma is basically a granulation tissue that is seen in the periapical region. Adhoda histopathology la cholesterol cleft is a very important feature. So these cholesterol clefts, where do they get derived from? Where do they come from? Is it from the adipose cells that are breaking down? Is it from the epithelial cells? Is it from the RBCs, or is it from the cholesterol? So I'm getting all answers, A, B, C, D. All choice mein varudhu answers are. Basically, cholesterol clefts are called so because they are made up of cholesterol. But in the cholesterol origin, it is from the RBCs. Okay. The cell wall of the RBCs, they will break down. Okay. The cell wall of the RBCs will break down. And from that phospholipid bilayer of the RBC cell wall, these cholesterols are formed. Okay. So they are called as the cholesterol clefts. Okay. Histological cholesterol cleft in solvom. Direct fluid la pathona, we call it as a cholesterol crystal. Okay, so basically deriving from the phospholipid bilayer, that is the cell wall of the RBCs. RBCs breakdown all varadha in the cholesterol cleft. Okay. Okay, now coming on to osteomyelitis. In which type of osteomyelitis you'll have a focal thickening of periosteum with peripheral reactive bone formation? The question itself is a description of the particular entity. In which type of osteomyelitis you'll have focal gross thickening of periosteum with peripheral reactive bone formation? Yes. Okay. Only a few of you have given the correct answer. This is also called as a Gares osteomyelitis. Gares osteomyelitis, or the other name, and Gares osteomyelitis is also called as a chronic osteomyelitis with proliferative periosteoitis. Okay, so basically there is a chronic osteomyelitis lesion, and in association, other characteristic feature and a periosteal proliferation. Okay, now suppose this is the mandible. Okay, you are seeing the tooth on the mandible. Okay, let us say that it is a molar tooth. Okay, now in the case of osteomyelitis, Gares osteomyelitis, you will also have thickening of the periosteum. Periosteum on the layer by layer, it will start to get deposited on the outer side. Okay, so this type of osteomyelitis, we call it as a Gares osteomyelitis. When you see the radiograph, especially the occlusal radiograph, in the layer by layer of periosteum formation. So that is called as the onion skin appearance or onion peel appearance, a very typical feature of Gares osteomyelitis. Okay, now which of these two lesions cannot be differentiated on the basis of size or radiographic appearance? Periapical granuloma, periapical cyst, periapical abscess, phoenixes. These are the 4 lesions that are in the mix. Idla vandu endha lesions vandu you cannot differentiate based on the size or radiographic appearance. Again, mixed answers. Okay, basically it is the periapical granuloma from the periapical cyst. Okay, if you remember the radiological appearance of all these lesions, periapical granuloma and periapical cyst both are chronic lesions. Okay, periapical granuloma is nothing but a chronic apical periodontitis. Okay, periapical cyst is again a chronic lesion. So both of these lesions are well defined radiolucencies with a thick radio-opaque border. Periapical granuloma, you will have a well defined radiolucency with a radio-opaque border. Periapical cyst will also show a radiolucency, well defined radiolucency with a radio-opaque border. Okay, so based on size or based on the radiographic appearance, you cannot differentiate the both. The only way to differentiate is based on the histopathology alone. Periapical abscess sort of feature enna, this is again a radiolucency, but it is not going to be well defined. It does not have a radio-opaque border. Okay, so that is the feature of a periapical abscess. It will be an ill-defined radiolucency in the periapical region. Okay. Okay, focal sclerosing osteomyelitis. Again, another type of osteomyelitis, chronic focal sclerosing osteomyelitis. Which is true about this? Is it due to excessive periosteal bone formation? Is it an extremely painful condition? Is it due to low-grade infection? Is it a common sequelae following sequestectomy? I think answer is straightforward to this. Focal sclerosing osteomyelitis, chronic focal sclerosing osteomyelitis, pulp polyp. Okay, both are almost similar entities. Okay, two separate and totally different lesions. Okay, pulp polyp totally within the pulp proliferate ஆகுது. இது வந்து bone lesion. ஏன் similarனு சொல்றேன்னா, both are basically a proliferative response. Okay, bone destruction பதிலா இங்க வந்து bone formation இருக்கும். Okay, secondly, both happen due to a low grade infection. Okay, அதுல பாத்தீங்கன்னா open carious lesion இருக்கும். In the focal sclerosing osteomyelitis la pathina, it is because of a low grade infection. Okay, and thirdly, both occur in individuals who have a very high tissue resistance. Very young individuals, young adults and teenage individuals la pathina, tissue resistance will be high, so there will be a proliferative response rather than a destructive response. So in all these 3 characteristics, you find that focal sclerosing osteomyelitis and pulp polyp are almost similar. Okay, so this focal sclerosing osteomyelitis, it is also called as the condensing osteomyelitis. Okay, you call it as a condensing osteomyelitis. Radiographica pathina, suppose there is a mandible with a grossly decayed tooth. You find that just around that grossly decayed tooth, there will be a small radio opacity. Okay, usually surrounding the molars with a grossly decayed tooth. Grossly decayed molar sutti pathina, there will be a periapical well-defined zone of radio opacity. Okay, so that is a chronic focal sclerosing osteomyelitis, also called as the condensing osteomyelitis. Okay, now this condensing osteitis or condensing osteomyelitis, இதுவும் benign cementoblastoma pathina, that is another entity, benign cementoblastoma. How are both of these lesions differentiated? How can you differentiate a condensing osteomyelitis from a benign cementoblastoma? Okay, இதுக்கு வந்து பாத்தீங்கன்னா answers பாத்தீங்கன்னா, it is either in relation to the vitality of the tooth or in relation to the radio opacity, whether it is attached to the tooth or whether it is not attached. இந்த ரெண்டு ஆப்ஷனை வச்சு differentiate பண்ணணும். Okay, so how can you differentiate? Now, vitality, is there any difference between condensing osteitis and osteomyelitis? Sorry, cementoblastoma? Or is there any difference in the radio opacity? The correct choice is that vitality cannot be a differentiating feature. Okay, you can have condensing osteomyelitis even in a vital tooth. A tooth that is vital but showing infection can still produce a condensing osteomyelitis. So vitality is not usually a differentiating feature. Okay, especially cementoblastoma பொறுத்த வரைக்கும், it is always associated with the vital tooth. Okay, so what is the difference in pathina? how exactly the radio opacity is in relation to the tooth. Cementoblastoma is the neoplasm of the cementum. So while radio opacity is going to be attached to the tooth directly, whereas osteitis, condensing osteitis is a reaction of the bone. So bone tooth nadula, that periodontal space will be definitely seen in the case of a condensing osteomyelitis. Okay, so the differentiating feature is the radio opacity. In the case of cementoblastoma, the radio opacity is directly attached to the tooth. In the case of a condensing osteomyelitis, because it is entirely a bone lesion, radio opacity kun tooth kun nadula, there will be a periodontal ligament space that separates both the two lesions. Okay. Okay, a couple of questions related to the space infections. Cellulitis. Okay, I think all of you know what is cellulitis. It is a spreading type of infection. It occurs mainly because microorganisms have certain enzymes. Okay, they liberate the enzymes streptokinase, fibrinolysin, and yeah, most of you are giving the correct answer. That is the hyaluronidase. Okay, so this question mainly I have given to make sure that you are aware of these three enzymes. Okay, cellulitis எதனால வருதுன்னா streptokinase, fibrinolysin and hyaluronidase இந்த மூணு lesions-னால வருது. Sorry, மூணு enzymes-னால வருது. Hyaluronidase will act on the hyaluronic acid that is seen in the what is it, the ground substance of the connective tissue, and it will help in the spreading of the infection. Streptokinase will act by again disintegrating or antagonizing the various chemicals that are produced by the inflammatory cells. Okay, fibrinolysin will again disintegrate any fibrin clot that is being formed. So all these will basically help to spread the infection. That is why cellulitis is spreading infection. It is not a focal infection. It keeps spreading to different spaces. Okay, now space infections, I'm sure oral surgery it will be discussed, I think. Okay, so I'm not going to discuss in detail about the different spaces. Just you should know about some of the spaces, the relationship between the various spaces you should know. Inferior portion of which space is also called as the pterygomandibular space? Is it the buccal space, temporal space, the infratemporal space, or the mesenteric space? And the space or the inferior portion is called as the pterygomandibular space. Yeah, again, correct answers from a few of you. It is the infratemporal space. Okay, so I'm not discussing in detail about the various spaces. Okay, just you should be aware of the different spaces. Okay, so when it comes to the oral cavity, commonly we know the sublingual space, submandibular space, and the submental space. Okay, submental space is anteriorly present between the two digastric muscles, anterior belly of the anterior belly of the digastrics. Okay, you have the submental space, and then pinnadi pathina submandibular and sublingual space separated by the mylohyoid muscle. When it comes to the pharynx, in relation to the pharynx, you have the retropharyngeal space that is behind the pharynx, lateral pharyngeal space on either side of the pharynx. Okay, when it comes to the mandible, on the inner aspect of the mandible, between the mandible and the medial pterygoid muscle, you have the pterygomandibular space. Between the mandible and the outer masseter muscle, you have the messenteric space. Pterygomandibular space is basically the space where you give the local anesthetic injection. Okay, inferior alveolar nerve block, you deposit the LA solution in the pterygomandibular space between the medial pterygoid muscle and the inferior border, inner surface of the ramus of the mandible. Okay, so again, this is another coronal view of the various spaces. Okay, we saw that there is a messenteric space between the ramus of the mandible and the masseter muscle. This messenteric space upward pathina, it is continuous with what is called as a superficial temporal space that is seen between the temporal fascia and the temporalis muscle. Okay, inner aspect, I told you, this is the space where you give the local anesthetic solution, that is the pterygomandibular space between the medial pterygoid and the ramus. Adoda upper aspect pathina, it is the infratemporal space, and this infratemporal space again on the superior aspect is continuous with the deep temporal space. Okay, so be aware of the different spaces where it is present, what are the boundaries of the different spaces, what are the important structures that are present in the different spaces. You definitely should be aware of all this oral surgery, this is going to be very important. Okay. Now next, let us go on to the infections. Okay, this is going to include all the bacterial, viral, and fungal infections. I'm going to discuss only the important lesions. Okay, so starting with giant cells found in the tubercular granuloma. What is the name given to the giant cells seen in the tubercular granuloma? That is tuberculosis. The giant cells. What is the name given? The most important confusion is between Langerhans giant cell and the Langerhans giant cell. Okay, I'm seeing the answers between A and B. Okay, C and D, I'm sure none of you will consider that as a answer. Langerhans giant cell or Langerhans giant cell, that is the confusion. Okay, now always remember tuberculosis vara giant cell on it is called as the Langerhans giant cell. Okay, spelling nyabam vechukonga, Langerhans giant cell, tuberculosis. Langerhans cell, okay, giant cell kadiyadu, Langerhans cell, that is nothing but a dendritic cell seen in the oral mucosal epithelium. Okay, oral epithelium, the antigen presenting cell that is seen in the oral epithelium. It is a type of a non-keratinocyte. It is a dendritic cell that is seen in the oral stratified squamous epithelium. Okay, so that is the Langerhans cell. Okay, so Langerhans cell is a non-keratinocyte, that is totally different. Tuberculosis irukadhu Langerhans giant cell. Okay, now when you see about giant cells, you have different types of giant cells in different lesions. Probably you can take a screenshot of this particular slide and try to memorize. Okay, and then the giant cell and then the lesion la varungaradu, you can take a screenshot and you try to memorize these giant cells, different types of important giant cells. Okay, okay, I think all of you might have taken a screenshot by now. Okay, okay, going on to the next question. Sulfur granules, very easy question. Sulfur granules seen in which lesion? Very straightforward question. Answer correct da varna ellarkittiyum. Yeah, I'm getting the correct answers also from all of you. It is basically a lesion that is actinomycosis. Okay, actinomycosis la sulfur granules irukum. Now confusion enna varuna in the particular question portha, the confusion is going to be when question is like actinomycosis is what type of lesion? It is a bacterial infection, a viral infection, a fungal infection, or it is a parasitic infection. In the mari question ketunda, I'm sure some of you might have a confusion about this particular entity. Okay, actinomycosis, even though it is ending with the term mycosis, it is not a fungal infection, it is a bacterial infection. Okay, so okay, by the time we just discuss about actinomycosis, some of you who want to take a screenshot, please take a screenshot. Okay, actinomycosis, even the name ends in mycosis, it is a bacterial infection. Earlier it was called as a fungus, ray fungus அப்படின்னு சொல்லிட்டு அதுக்கு earlier ஒரு misnomer கொடுத்திருந்தாங்க. Okay, because it had a typical ray like appearance in the histopathological view. மைக்ரோஸ்கோப்ல பார்க்கும்போது ஒரு லாங் ஸ்லெண்டர் ரே லைக் ஹைஃபை மாதிரி அப்பியரன்ஸ் இருக்கிறதுனால they initially called it as a ray fungus, but later on it was identified as a bacteria. Okay, so actinomycosis is a bacterial infection. அதுல வந்து you'll have board like fibrous or thick board like enlargement of the face, cervicofacial region will be there, and you'll have multiple draining sinuses. The sinus lende vara fluid la pathina, you'll have small yellowish granules. These are called as sulfur granules because they resemble the sulfur. Okay, biochemistry la neenga paathirpinga, haze test la paathirpinga sulfur granules. You use the sulfur powder in haze test, so adla vandu pathina yellowish powder ah irukum the sulfur granules. So and the madri appearance irukadnala they are called as the sulfur granules in the actinomycosis. These yellowish granules are nothing but the bacterial colonies. Okay, actinomycosis colonies vandu they have this yellowish appearance, so they are called as a sulfur granules. Okay, Lipschutz bodies, again these are inclusions, cell inclusions that are seen in certain infections. Okay, one such inclusion is what is called as a Lipschutz bodies. Endha lesion la varum, in which lesion you have these Lipschutz bodies? Chickenpox, herpangina, smallpox, or herpetic stomatitis. So this is again a type of a viral inclusion. Okay, so it is a very typical feature of a herpetic stomatitis, primary herpes infection. You have these Lipschitz bodies. Again, the reason for this question is various inclusion bodies can be asked as questions. Okay, so again, take your time and take a screenshot of this particular inclusion bodies that can be seen in different viral infections: rabies, okay, variola, vaccinia, herpes simplex virus, varicella zoster virus, cytomegalovirus, measles. In the mari lesions la, you have different type of inclusion bodies, named inclusion bodies. Okay, Negri bodies, passion bodies, Cowdrey A, Cowdrey B, இந்த மாதிரி நிறைய types of inclusion bodies possibilities இருக்கு. So you can have a question on any of these inclusion bodies. Okay, guarnary bodies are seen in which infection அப்படின்னு ஒரு question வரதுக்கான chances இருக்கு. So it is better if you memorize all these inclusion bodies in the different types of infections. Okay. Okay. Now again, there's another very straightforward question. So herpetic whitlow is an infection that is seen in which entity, in which part of the body you can have a herpetic whitlow? Yes, it is the, yeah, answer is finger. Okay, whitlow, herpetic whitlow is basically a infection of the finger, especially the finger bed. The nail bed of the fingers are typically involved in the herpetic whitlow. It is very typically seen in herpes simplex virus infection. Okay. Okay, just a minute. Yeah. Okay, now again, coming on to another property of the infections, abscess formation is a characteristic feature of a particular microorganism, particular group of microorganism. So in which group of microorganism you will find the abscess formation? Is it the virus, Rickettsia, the streptococci, or the staphylococci, in which you will find the abscess formation? Okay, someone has asked me about foul pox, sorry, Bollinger bodies. Okay, inclusion bodies, Bollinger bodies edla varun ketirukanga. Bollinger bodies are also seen in foul pox. Okay, so probably I can make a note of it. Bollinger bodies is seen in foul pox infection. Okay, coming on to this question, abscess formation is a typical feature of staphylococcal infections. Okay, so just now we saw streptococci. They produce the enzymes streptolysin, fibrinolysin, streptokinase, and hyaluronidase. So they have a spreading type of infection. Streptococcal infections, they are not localized. They are always spreading type of infection. Staphylococci have a tendency to produce localized infections. Abscess formation, osteomyelitis, both are typical features of staphylococcal infections. Viruses are பொறுத்த வரைக்கும், usually viruses tend to produce vesicles. Okay, not all, but most of the viral infections will produce vesicles. Okay, explosive and widespread form of secondary syphilis is termed as what? Okay, now infections are பொறுத்த வரைக்கும், bacterial infections la syphilis tuberculosis very important. MCQ point of view la very important, because both are age old infections. Syphilis seri, tuberculosis seri, there are descriptions right from few centuries ago. Okay, so different named entities are seen in both syphilis and tuberculosis. Okay, one such named entity is a widespread form of syphilis that is called as a Lues maligna. Okay, maligna refers to a malignant nature, an aggressive nature. Lues is another name for syphilis. Okay, so syphilis or the other name is Lues. So Lues maligna is a widespread and explosive form of secondary syphilis. Chancre is a feature that is seen in the primary syphilis. Okay, gamma is a feature of the tertiary syphilis. Condyloma can be seen in the secondary syphilis. So over a type of syphilis என்னென்ன lesions இருக்குங்கிறத you should definitely be aware of. Again, Fournier's molars, I think we have discussed this earlier also. Fournier's molars are associated with, is it the congenital syphilis, Fabry-Anderson syndrome, Apert syndrome, or progeria? Yeah, it is a feature of the congenital syphilis. Congenital syphilis, you have the Hutchinson's triad, that is Hutchinson's teeth, the eighth nerve deafness, and the interstitial keratitis, that is the Hutchinson triad. Congenital syphilis is also associated with Moon's molars or Fournier's molars, molars that are having an abnormal occlusal pattern. Okay, that is called as the Fournier's molars or the Moon's molars. Congenital syphilis la vandu you have something called as the Higgs-Menakis sign. Okay, Higgs-Menakis sign na the sternocleidomastoid oda sternal end kitta you will have a thickening of the uh, bones. Okay, so that is the Higgs-Menakis sign. So in the many different named entities can be seen in congenital syphilis. Okay, so Fournier's molars is also a feature of congenital syphilis. Fabry-Anderson syndrome is a glycogen storage disorder, not related to Fournier's molar at all. Apert syndrome is again a craniosynostosis. Okay, craniofacial dysostosis. You have this Apert syndrome. Progeria is a premature aging. Okay, aging at a very young age. Very young age on the old age kind of features on the progeria. Okay. Okay, this I have already mentioned just now. Higgs-Menakis sign is a feature that is seen in I have mentioned this just now. It is a feature that is seen in congenital syphilis. So sternocleidomastoid region, joint where the clavicle joins the sternum. In that particular region, in the sternoclavicular region, you will have a thickening of the clavicle. Okay, so that is called as the Higgs-Menakis sign, a very classic feature of congenital syphilis. Okay, so it is a unilateral enlargement of the sternoclavicular portion of the clavicle. Okay, it is seen in the congenital syphilis. Other features we have already seen. Hutchinson's triad பார்த்துட்டோம். அதுல வந்து Hutchinson's teeth, eighth nerve deafness, and you also have the interstitial keratitis. Mulberry molars or Moon's molars or Fournier's molars also seen in congenital syphilis. Also you have the ragates. Ragates na cracking in the lips. Okay, especially at the angle of the lips, you have the cracks, horizontal fissures. That is called as the ragates. That is seen in congenital syphilis. You also have what is called as the saber shin. Saber na a sword-like appearance. Okay, in the mari or sword-like appearance is called as the saber. So in the congenital syphilis la pathina, in the particular children order shin. Okay, the bone of the shin will have this sort of a saber-like appearance that is called as a saber shin. Okay, cranial nerve involved in the Ramsay-Hunt syndrome. It's a trigeminal, facial, glossopharyngeal, or oculomotor. So we should know what is Ramsay-Hunt syndrome. Herpes zoster that is involving a cranial nerve that is called as the Ramsay-Hunt syndrome. The cranial nerve that is involved is the facial nerve. Okay, so basically herpes zoster that is involving the facial nerve is called as the Ramsay-Hunt syndrome. Okay, now this is again a slightly tricky question. Commonest opportunistic infection in AIDS cases in India. Okay, specific AIDS patients in India abdin ketangana, your answer should be very specific to India. Okay, இதே வந்து overall WHO ஓட announcement என்ன பார்த்தீங்கன்னா commonest opportunistic infection in AIDS பார்த்தீங்கன்னா you can have either pneumocystis or some other sort of a lung infection. But when it comes to India, the commonest is going to be the tuberculosis. Okay, so most of you have given the correct answer. India பொறுத்த வரைக்கும் commonest opportunistic infection in AIDS is going to be the tuberculosis. Overall, okay, Indian specific கேட்காம overall if they are giving you a choice and giving you a question like what is the commonest opportunistic infection in AIDS அப்படின்னு கேட்டா your answer should be candidiasis. You should look for candidiasis first. Candidiasis இல்லைன்னா you can go for tuberculosis. அது overall கேட்கும்போது India specific கேட்கும்போது always better to go for tuberculosis as the right choice. Okay. Okay. Oral ulcers that are painless are associated with which lesion? Painless oral ulcers. Secondary herpes, primary syphilis, tuberculosis, primary herpes. எதுல வந்து painless oral ulcers இருக்கும்? All of these are associated with oral ulcers, but the ulcers will be painless in exactly. Many of you have given the correct answer. Primary syphilis, chancre. Okay, we call it as a chancre. Chancre is a painless condition. Secondary herpes, okay, that is basically the herpes zoster or herpes. Secondary herpes la, you have very painful ulcerations. Tuberculosis also is associated with very painful ulcerations in the oral cavity. Primary herpes, as it is we know, it is associated with pain and erosion and burning sensation in the oral cavity. Okay, so painless means it is the primary syphilis, Shankar. Okay, rigidity of the facial muscles, that is called as the rhizus sardonicus. This term rhizus sardonicus means rigidity of the facial muscles. It is associated with which condition? Tetania, tetanusa, or leprosy or acnomycosis. இதில் பார்த்தீங்கன்னா leprosy and acnomycosis you can straight away eliminate. Okay, you know that it is not associated with either leprosy or acnomycosis. So it has to be either tetany or tetanus. Which is correct? Most of you have given the correct answer, that is tetanus. Some of you have opted for tetany. Okay, ரெண்டுத்துக்கு என்ன difference னு பாத்தீங்கன்னா tetanus is an infection, okay, caused by Clostridium tetani. So this particular infection is associated with rigidity of various muscles including the facial muscles. So facial muscles involve ஆகும்போது you have this rhizus sardonicus, almost constantly ஒரு sarcastic look இருக்கிற மாதிரி இருக்கும். Okay, it is almost like your facial muscles are constantly stretched. A sarcastic or look கொடுத்துட்டே இருக்கிற மாதிரி இருக்கும். That is called as the rhizus sardonicus. Okay, that is associated with Clostridium tetani infection, that is tetanus. Tetany என்னன்னு பாத்தீங்கன்னா, this is a condition where there is a increased calcium in the blood that will trigger the voluntary twitching and contraction of the muscles. Okay, when there is a calcium imbalance in the blood, okay, you'll find that the blood muscles will become easy to trigger and they will start to easily show twitching and contractions. So that is called as tetany. Tetany identify பண்றது, you have two important signs. You have what is called as a Chostek sign and then you have what is called as a Troisios sign. இது ரெண்டும் again I'll show it in a separate screenshot that you can take a screenshot of. Okay. Okay, cancerous involvement is seen with which condition? Okay, out of the following choices, one of this is associated with malignant change, a tendency to turn into malignancy. Which is true? Shankar, mucus patch, syphilitic glossitis or gamma? எதுல வந்து malignancy வரதுக்கான chances அதிகமா இருக்கு? Again, some of you have given the correct answer. Syphilitic glossitis. Oral squamous cell carcinoma ஓட etiology பாத்தீங்கன்னா ஷேஃபர்ஸ்லயோ நெபிலியோ எங்க பாத்தீங்கனாலும் first and foremost tobacco and tobacco chewing habits எல்லாமே கொடுத்திருப்பாங்க. அது இல்லாம if you go back and read the other etiological factors, one of the factors will be syphilis. Okay, now syphilitic glossitis, syphilis you can have loss of the papillae of the tongue. Again, as I mentioned, papillae loss, it is going to be usually the filiform papilla. Okay, so filiform papilla will be lost and there will be glossitis of the tongue. And in the Mari condition, due to the constant chronic trauma and irritation, there is a tendency for developing oral squamous cell carcinoma and syphilitic glossitis. Very, very, very rare nowadays because incidence of syphilis itself has become very rare nowadays. But still you should know that syphilitic glossitis can be a predecessor for oral squamous cell carcinoma. Okay. Okay, now already we have seen osteomyelitis and focal infection like abscess can be produced by Staphylococcus. அது இல்லாம which of the following organisms can produce osteomyelitis? Histoplasma, Candida, Mycobacterium tuberculosis or Cryptococcus? எதுல வந்து osteomyelitis வரதுக்கான chances அதிகமா இருக்கு? இது வந்து you have to think slightly laterally. Think about the clinical features and see in which of these lesions you have read about a lesion that is involving the bone. அந்த மாதிரி ஞாபகம் வச்சிருந்தா you will come across this correct answer. You will be able to guess that it is Mycobacterium tuberculosis. Mycobacterium tuberculosis, sometimes you can have tuberculosis of the spine. Okay, so that is basically a form of osteomyelitis caused by the tuberculosis. Okay, so as I mentioned, syphilis there are various named entities. Similarly, tuberculosis, there are various named entities. Tuberculosis is also called as consumption disease because tuberculosis vandale, there will be a drastic weight loss. It will appear almost like the infection has consumed the entire person. Okay, so it is also called as a consumption disease. Tuberculosis of lymph nodes is also called as the scrofula. Tuberculosis of the skin is called as the scrofuloderma. Tuberculosis of the spine is called as the Pott's disease. இதுதான் வந்து a form of osteomyelitis. Okay. Tuberculosis of the lymph node is also called as a cold abscess because inflammation இருக்காது. Even though there is abscess formation, it appears very cold and normal to touch. So it is called as a cold abscess. You have also what is called as the collar stud abscess. Okay, இதோட details என்ன நான் சொல்ல போறதில்லை இப்போதைக்கு. Just remember that tuberculosis lymph node can also be called as the collar stud abscess. Okay, and then the disseminated form of tuberculosis is what is called as the miliary tuberculosis. So tuberculosis related, there are so many different terminologies. Try to be aware of all these different terminologies and remember all these different terminologies. Okay, again a couple of minutes break before going on to the next on benign and malignant tumors of the oral cavity. Okay, just a short break, just 1 or 2 minutes. Drink water or tea, then join in just a couple of minutes. Okay. Okay, so let us continue with some questions on benign and malignant tumors. Okay, now I will be discussing only some of the abnormal or unique features. Okay, epithelial malignancy, pre-malignant lesions, leukoplakia, and all those things will be discussed in oral medicine. Okay, so we'll be seeing some of the slightly abnormal or rarer entities. Okay, and some of the important terminologies to remember, all that we'll be discussing in this particular section. Okay. Okay, starting with a very straightforward question. Single or multiple folds of hyperplastic tissue in alveolar vestibule occurring in association with a flange of an ill-fitting denture. What is the most likely diagnosis? Is it the inflammatory papillary hyperplasia, inflammatory fibrous hyperplasia, giant cell epulis, or congenital epulis? Now, I think giant cell epulis and congenital epulis, all of you can easily eliminate straightforward. Okay, epulis nale a small growth in the gingiva. Description pathina hyperplastic tissue in the alveolar vestibule, so it is not going to be an epulis. Okay, confusion is whether it is an inflammatory papillary hyperplasia or inflammatory fibrous hyperplasia. Okay, this particular entity we call it as the epulis fissuratum. Okay, we also use the term epulis fissuratum to denote this particular entity. Correct description, histopathological term is inflammatory fibrous hyperplasia. Okay, and that is the fibrous tissue proliferator. You have this particular fold of mucosa that is called as the inflammatory fibrous hyperplasia. Inflammatory papillary hyperplasia enga varun pathina, this you usually see in the palate. Okay, palate small nodular projections that can be seen in association with a long-term denture wearing. Okay, denture remove பண்ணாம constant போட்டுட்டே இருந்தாங்கன்னா you can have small nodular growths in the palate, hard palate region. That is the inflammatory papillary hyperplasia, can be seen in smokers also. Okay, so that is the inflammatory papillary hyperplasia. So don't confuse between the papillary hyperplasia and the fibrous hyperplasia. Okay, one of the most common types of arrangement of tumor cells in fibrous histiocytoma. What pattern of arrangement of tumor cells you will be able to see? Storiform pattern, herringbone pattern, ductal pattern, or glandular pattern? Yeah, it is the storiform pattern. Okay, many of you have given the correct answers. Storiform pattern, fibrous histiocytoma. Herringbone pattern, fibrosarcoma. Okay, herringbone pattern ale, it is like a scales of a fish, sorry, bone of a fish. Okay, so this sort of an appearance is the herringbone pattern. Okay, and this is seen in fibrosarcoma. Storiform pattern enna pathina, it is like a matted pattern. Okay, or intervening or matted type of appearance is called as a storiform pattern, that is seen in fibrous histiocytoma. Ductal pattern and glandular pattern very commonly seen in various lesions. Adu unique entity in kediyadu. Usually salivary gland lesions la ductal pattern and glandular pattern can be seen very commonly. Okay, Antony A type microscopic pattern is seen in which type of lesion? Neurilemoma, neurifibroma, Hodgkin's disease, or verrucous carcinoma? எதுல Antony இந்த மாதிரி type of patterns இருக்கும்? Any answers? Yeah, some of you have called it as Hodgkin's lymphoma, some of you have given an option as neurilemoma. Correct choice is neurilemoma, also called as the schwannoma. Okay, schwannoma kodutunda, I am sure all of you would have answered it correctly. Schwannoma is the other name for neurilemoma. Idhila you have the Antony and Antony B type of arrangement. Antony A is the arrangement where the cells are arranged in a palisading pattern. Okay, cells on the parallel to each other, palisading irukum. Nadula vandu you have the large verrucae bodies. That is a feature of Antony A type of pattern in the neurilemoma or schwannoma. Okay, neurofibroma does not have any specific pattern. Important feature in neurofibroma, there will be lots of mast cells. Okay, the inflammatory cells, mast cells வந்து நிறைய வந்து neurofibroma ல இருக்கும். Hodgkin's disease, you have what is called as the you have the important giant cell, that is the Reed-Sternberg cell. Okay, that is a characteristic feature of the Hodgkin's disease. Reed-Sternberg cell oda variants, popcorn cell illa vesicular cell, இந்த மாதிரி செல்ஸும் வந்து Hodgkin's lymphoma ல இருக்கும். Verrucous carcinoma la what is the important feature appdin pathina, you have what is called as the parakeratin plugging. Okay, you have something called as the parakeratin plugging. This is a very typical feature of the verrucous carcinoma. Okay. Okay, neurofibroma can also be a component of which disease or syndrome? Von Willebrand disease, von Reckling-Hausen's disease, van der Waals syndrome, or von Ebner's disease. எதுல வந்து neurofibroma is a component? Yeah, straightforward question. Von Reckling-Hausen's disease of the skin is the other name for neurofibroma. Okay, so basically it is multiple neurofibromas, neurofibromatosis அப்படினு சொல்லுவோம். There will be multiple neurofibroma like lesions. You have what is called as the Caffiolier spots. Okay, இந்த மாதிரி features எல்லாம் இருக்கிறது வந்து we call it as a Van Reckling-Hausen's disease of the skin. Van Reckling-Hausen's disease of bone is also there. Okay, this is seen in hyperparathyroidism. That is basically the osteitis fibrosa cystica அப்படினு சொல்லுவோம். That is multiple bone lesions. Okay, small areas of bone resorption throughout the bone, that is called as the osteitis fibrosa cystica or brown tumor. Multiple brown tumors in the bone can be seen. That is also called as a Von Reckling-Hausen's disease of the bone. Okay, so Von Reckling-Hausen's disease of skin na enna theriyano, Von Reckling-Hausen's disease of bone na enna you should be aware of. Okay, again, Staghorn pattern of blood vessels, it is seen in which lesion? hemangioma, hemangioendothelioma, hemangiopericytoma, or angiosarcoma? Again, many correct answers. It is a typical feature of hemangiopericytoma. Staghorn அப்படின்னா இந்த deer மானோட கொம்பு மாதிரி இருக்கிற ஒரு branching type of pattern. You find it in the case of hemangiopericytoma. The blood vessels will have this sort of an appearance, so we call it as a staghorn pattern. A very typical feature of hemangiopericytoma. Okay, port vein stain is a common component of which syndrome? Osler-Weber-Rendu syndrome, Kelly-Patterson syndrome, Sturge-Weber syndrome, or Klinefelter syndrome? எதுல port vein stain இருக்கும்? Any guesses? Any answers? Yes, again, correct answers, many of you. It is a typical feature of Sturge-Weber syndrome. Okay, Sturge-Weber syndrome la important manifestation is port vein stain. Port vein stain என்னன்னு பாத்தீங்கன்னா there will be a very large reddish patch. Okay, a type of a hemangioma, a very large reddish patch on the head and neck region. Okay, usually on the face, one side of the face, it will be completely red. Okay, because of hemangioma on that particular region. So could be associated that there can be some other abnormalities like radiograph, you can have this tramline calcification in the brain. All that will be seen in the Sturge-Weber syndrome. Osler-Weber-Rendu syndrome, you have something called as the hereditary hemorrhagic telangiectasia. Okay, multiple small telangiectatic spots can be seen in Osler-Weber-Rendu syndrome. Okay, Patterson-Kelly syndrome is nothing but a feature of iron deficiency anemia, the esophageal webbing, okay, bald tongue, all that will be together called as the Patterson-Kelly syndrome or Kelly-Patterson syndrome. Okay, it is seen in iron deficiency anemia. Klinefelter syndrome, I'm sure all of you know, it is a chromosomal abnormality where there is a XXY type of chromosome. That is a Klinefelter syndrome. Oral manifestation, we already saw, taurodontism can be a feature of Klinefelter syndrome. Okay. Okay, now this is interesting. Most probable diagnosis for multiple translucent vesicle-like lesions on anterior two-thirds of tongue that appears enlarged. Tongue on the macroglossia madri irukku. Anterior two-thirds are small vesicular lesions, whitish vesicular translucent lesions irukku. What is the probable diagnosis? Again, most of you have given the correct answer. You should not confuse this with the pemphigus vulgaris. Neurilemoma, neurofibroma definitely won't produce this translucent lesion. It will be a firm nodules. Okay, this is a typical feature of lymphangioma. Okay, lymphangioma of the tongue. Couple of abnormal or distinct entities that you can remember. One is in the translucent appearance, it will look like what is called as a tapioca pudding appearance. Okay, I'm not sure how many of you know this particular term. Okay, tapioca pudding appearance and so on. English la pathology book la pathina you come across this term tapioca pudding. Tamil la translate pananuna tapioca pudding is nothing but a javarsi payasam. Okay, so adha nyabam vechittina you will be able to remember multiple translucent small nodular vesicles. Okay, so this tapioca pudding appearance is seen in lymphangioma. Okay, it's also called as the frog's egg appearance. Frog or eggs pathina, again there will be small translucent ball-like structures and it will be seen in clusters. And the mari appearance again tongue la irukum. So either the frog's egg appearance or tapioca pudding appearance refers to the lymphangioma, especially in the tongue. You can see this sort of an appearance. Okay, Kaposi sarcoma, I'm sure all of you must have come across this term when you read about AIDS. Okay, what is the virus that is causing the Kaposi sarcoma? If someone has raised hand, Priyanka, enna question konja unmute pannittu you can please ask the question. Or you can type the question in the chat box also. Okay, meanwhile I'll be discussing the other questions. You can please type the question in the chat box. Okay, Kaposi sarcoma also is now believed to be caused by which virus? Even though it is a feature of AIDS, you find that this particular entity is caused by the human herpes virus 8, HHV8. Okay, again, many of you have given the correct answer. AIDS vandalum It is not caused by the human immunodeficiency virus. Rather, it is caused by additional infection, superadded infection by the human herpes virus 8, HHV8. Okay. Okay, hemangioma can be best classified as, is it a neoplasm, is it a choristoma, a hamartoma, or a cyst? What is a hemangioma? This question is mainly to make you aware of the different terms. Okay, you should know what is hamartoma, what is choristoma, what is neoplasm. Hemangioma is also called as a hamartoma. Hamartoma is basically an abnormal proliferation of tissues that are native to a particular site. Okay, so skinல எடுத்தீங்கன்னா அங்க இருக்கிற epithelium இல்ல அன்டில்ல இருக்கிற blood vessel, if there is just an abnormal proliferation, that is due not because of any underlying cause, or it is not neoplastic in nature, you call it as a hamartoma. Choristoma is when normal tissue occurs in an abnormal location. Typical example is the Fordyce's granules. Okay, sebaceous glands seen inside the oral cavity is called as the Fordyce's granules. Okay, so that is a choristoma. You know what is the neoplasm and you know what is a cyst. Okay, so you should know the examples for hamartoma and choristoma also. Hamartoma ki innor example enna, we use AOT, adenomatoid odontogenic tumor, is also referred to as a hamartoma by some authors. Adayum nyabagam vechukonga. Okay, so hemangioma and AOT can be examples of hamartoma. Okay, which of the following benign lesion resembles squamous cell carcinoma clinically and microscopically? It is a benign lesion, but clinical microscopic its appearance is very similar to squamous cell carcinoma. It can be mistaken for a squamous cell carcinoma. Correct answer is, yeah, most of you answered it correctly. It is a keratoacanthoma. Keratoacanthoma is also called as a self-healing carcinoma. Okay, very small lesion or nodular growth மாதிரி வரும், அப்புறம் central crater like formation இருக்கும். It looks very aggressive in appearance. Clinically பார்க்கும்போது ஒரு nodule with an ulceration பார்த்தாலே we start to think of a malignancy because it is having an aggressive sort of a behavior. But if you observe the lesion over a period of time, within a couple of weeks, usually it will gradually undergo healing by itself and it will completely disappear. Okay, so that particular lesion is called as a keratoacanthoma, also called as a self-healing carcinoma. Clinically resembles a squamous cell carcinoma. Histopathological பார்க்கும்போது you have what is called as a pseudo epitheliomatous hyperplasia. Okay, epithelioma squamous cell carcinoma, pseudo epitheliomatous அப்படினா epithelioma மாதிரி squamous cell carcinoma மாதிரி ஒரு false appearance கொடுக்கிற ஒரு proliferation இருக்கும். Okay, so there won't be any dysplasia, but there will be so much of proliferation that it looks almost like a squamous cell carcinoma. Okay. Okay. Again, a very simple question. Aptropfung effect is seen in which lesion? Junctional nevus, pemphigus, aphthous ulcer, or erythema multiforme? Yeah, it is very typical feature of junctional nevus. Aptropfung அப்படினா dropping off. Okay, மேல இருந்து கீழே விழுந்துடுச்சு அந்த மாதிரி ஒரு appearance. So இதுல பாத்தீங்கன்னா melanocytes. Okay, it is seen in basically nevus, junctional nevus. So in the nevus cells or the pigment cells that are seen in the epithelium can also be seen in the underlying dermis or in the submucosa. So பார்க்கும்போது epitheliumலயும் nevus cells இருக்கு, connective tissueலயும் nevus cells இருக்கு. Microscope பார்க்கும்போது it looks like epithelium வந்து கீழே விழுந்த மாதிரி இருக்கும். So this sort of a dropping off effect, we call it as a aptropfung effect, a typical feature of a junctional nevus. Okay, now this is important from a clinical point of view also. The sign or symptom that is most suggestive of a metastatic disease. Okay, suppose a patient comes to you in the 4 lesion எந்த lesion எந்த complaint ஓட வந்தா you should be aware that okay, this could be a malignancy, we should be very careful அப்படின்னு எதை வந்து you should be considering very important feature. Yeah, most of you again have given a correct answer. Paresthesia, unexplained paresthesia oda patient vandale, think that there is a possibility of a metastatic malignancy, a renal carcinoma or a carcinoma from the breast or lungs can metastasize into the mandible, and when it metastases into the mandible and involves the inferior alveolar nerve, then you can have numbness or paresthesia without any underlying cause. Okay, so in such case, when the patient comes to you with such symptom, always you have to rule out a metastasis. Okay, now the following are all malignancies. Burkitt's lymphoma, nasopharyngeal carcinoma, Hodgkin's lymphoma, hepatocellular carcinoma, எல்லாமே malignancies. Which of the following does not have a viral etiology? Only 3 of these lesions have a non-viral etiology. One does not have a viral etiology. Which does not have a viral etiology? So I'm getting mixed answers. The correct option is Hodgkin's lymphoma. Hodgkin's lymphoma in the virus direct correlation established pannala. Okay, so there is no cause and effect relationship between a viral infection and a Hodgkin's lymphoma, whereas Burkitt's, nasopharyngeal carcinoma, hepatocellular carcinoma all have very well-known viral etiological agents. Again, screenshot time. Take a screenshot of this particular table. What are the various viruses implicated in the different neoplasms of the head and neck region? Epstein-Barr virus, Burkitt's lymphoma, and nasopharyngeal carcinoma. Hepatitis B and hepatitis C associated with hepatocellular carcinoma. Human papillomavirus with squamous papilloma and cervical, oral, and anogenital cancers. HTLV associated with adult T-cell leukemia. HHV8 we saw already associated with the Kaposi sarcoma. Okay, so take a screenshot and go through this table again and be very sure about these viral etiological agents for malignancies. Okay, which of the following epithelial changes commonly signifies a precancerous condition? Okay, so epithelial changes, like pre-malignancy, you have lots of epithelial changes. Okay, you must have read about the dysplasia, architectural changes and cellular changes நிறைய பார்த்திருப்பீங்க. இதுல எது வந்து associated with pre-malignancy? Again, right answer from most of you, it is dyskeratosis. Okay, hyperkeratosis means just a increased thickness of keratin. Keratin is produced in more than normal in an abnormal location. Like for example, buccal mucosa excess keratin formation irundhuchna, it is hyperkeratosis. Parakeratosis means when there is thick amount of parakeratin. Acanthosis is thickness of the spinous layer of the epithelium is increased. Dyskeratosis refers to a disordered keratin formation. Okay, so disordered means keratin usually in the superficial layer la mattum da irukum, but sometimes if it is going to be formed in the basal layer illa parabasal layer liye keratin form agudhu, individual cell keratinization irukku andha marina, we call it as dyskeratosis, which is a very good indicator of pre-malignancy. Okay, osteosarcoma presents a radiographic picture resembling which appearance? Sunburst, cotton wool, soap bubble, ground glass appearance. Straightforward question. It is a typical feature, that is sunburst appearance. Okay, sunburst appearance ஏன் வருதுன்னு பாத்தீங்கன்னா, suppose this is the mandible that is involved with the, okay, you have the mandibular teeth and then you have the mandible that is involved with the osteosarcoma. Okay, so you will have a enlargement of the mandibular cortical spaces. இந்த மாதிரி cortex enlarge ஆகும்போது என்ன ஆகும்னா, you can have trabeculae that are forming in a radial fashion. Okay, you can have trabeculae that are forming in this particular direction. Okay, so this gives an appearance of a sun ray like of appearance. So this is called a sunburst appearance or a sun ray appearance, a typical feature of osteosarcoma. Cotton wool appearance, we see it in Paget's disease, or we also see it in the fibrous dysplasia. Basically mixed radiolucent radiopaque lesion, we call it as a cotton wool appearance, can be seen in fibrous dysplasia or even in Paget's disease. Ground glass appearance, typically we call it in fibrous dysplasia. Okay, cotton wool we usually use it for Paget's disease. And soap bubble appearance is multiple radiolucencies, multilocular radiolucency, can be seen in lesions like ameloblastoma or even the aneurysmal bone cyst. You can see. Okay, so some of the patterns in oral pathology, again take a screenshot of some of these patterns, probably 1 or 2 slides I think. Just take a screenshot of these patterns. Okay, so Swiss cheese pattern, Corbino necrosis, storiform pattern, staghorn pattern, herringman pattern, some of this we have already discussed. So endha lesion la enna pattern typical ah irukungaradu, you can take a screenshot of this particular slide. Okay, and also this particular slide, tombstone appearance, chicken wire appearance or rosette formation. What are the different lesions where you get all this type of patterns? And take a screenshot of these two slides. Okay. Fine. Okay, now going on to the next section, that is odontogenic cyst and tumor. Now, starting with a very straightforward question, dentigerous cyst, we must have seen about the different radiographic varieties. Okay, so which is not a radiographic variety of the dentigerous cyst? Central, collateral, lateral, or circumferential? Which is not a radiological variant of dentigerous cyst? Yeah, you don't have what is called as a collateral. Collateral variant edum kediyadu. You can have a central dentigerous cyst, a lateral, or a circumferential. It depends on how the radiolucency is in association with the tooth. Okay, so in the case of central, you'll have radiolucency that is entirely surrounding the crown of the impacted tooth. In the case of lateral, you'll have a radiolucency that is especially towards one side of the tooth alone. Okay, and circumferential you'll have the radiolucency that is seen around in the circumference or rubber tube mari sutti or circumference to cervical region, you will have a radiolucency. That is the circumferential variant. You don't have anything called as a collateral variant. Okay, multiple odontogenic keratocyst, basal cell carcinoma, and bifid ribs. Enna syndrome la irukum? This syndrome is also called as the nevoid basal cell carcinoma syndrome. It's also referred to as the Gorlin-Gall syndrome. Okay, so Gorlin-Gall syndrome features will include multiple odontogenic keratocysts. You will have basal cell carcinomas. You will have bifid ribs. There are so many other features also. These are the important features. Okay, so it is also called as the nevoid basal cell carcinoma syndrome or the Gorlin-Gall syndrome. Okay, Gardner syndrome என்னன்னு பாத்தீங்கன்னா இதுல வந்து multiple osteomas இருக்கும். Okay, and importantly, multiple supernumerary teeth will be seen in Gardner syndrome. Greenspan syndrome is associated with lichen planus. Lichen planus with diabetes mellitus and hypertension, we call it as Greenspan syndrome. Okay, and Patterson-Kelly syndrome we have already seen. Iron deficiency anemia la irukadhu. You have the Kelly-Patterson syndrome. Okay, so this appearance we already saw just now in that particular screenshot slide. Picket fence or tombstone appearance of basal cell layer of a cyst lining, a typical feature of which cyst? Odontogenic keratocyst, dentigerous, lateral periodontal cyst, or radicular cyst? It is a very typical feature of the odontogenic keratocyst. So picket fence appearance or tombstone appearance na ennan theriyum. Okay, picket fence appearance na ennan pathina in the I think Indian number railway station la pathina sometimes you have the fence around the railway tracks. Okay, neat in the mari kuchi kuchiya irukum. Okay, and these are joined together by in the mari or fence irukum. So this sort of appearance you call it as a picket fence appearance. Histopathological you have the basal layer of cells that are all tall columnar. Okay, and you have the nucleus which is all parallel to each other and arranged at the same level. So this sort of an appearance, you call it as a picket fence appearance, also called as a tombstone appearance, row of tomb appearance. Okay, graveyards la pathina sometimes you can have tombstones that are arranged parallel to each other. So that is the tombstone appearance. Very typical feature of OKC. All of the following except which is example of a developmental odontogenic cyst. Read the question carefully. Okay, enna kekranga which of the following is not a developmental odontogenic cyst? Choices pathina ellame odontogenic cyst da. Radicular cyst, calcium odontogenic cyst, gingival cyst, as well as the lateral periodontal cyst, all are odontogenic cyst. Okay, but one of the following is not developmental. Which is not developmental in nature? So yeah, couple of you have given the correct answer. Radicular cyst is not developmental in nature. Okay, even though it is odontogenic in origin, etiology enna pathina it is because of a inflammation. Okay, dental caries resulting in apical infection, periapical infection that can result in periapical granuloma and then a periapical cyst formation. Okay, so etiology is inflammation in this case. whereas the rest all are developmental in origin. Okay, so this radicular cyst is an inflammatory odontogenic cyst. The other three are developmental odontogenic cyst. Okay, another straightforward question. Botryoid odontogenic cyst is a variant of which odontogenic cyst? Gingival cysta, lateral periodontal cysta, OKCA, or calcifying odontogenic system? Yeah, again, straightforward question. Many of you have given the correct answer. Lateral periodontal cyst or a variant of botryoid. Okay, botryoid means, the term botryoid means resembling a cluster of grapes. Okay, grapes, cluster of grapes or appearance called as botryoid. Okay, so usual lateral periodontal cyst is a unilocular radiolucency. Sometimes you can have a multilocular appearance, a multicystic appearance in lateral periodontal cyst. So that sort of a multilocular appearance or a multicystic variant is called as a botryoid odontogenic cyst. Okay. Carcinoma arising from odontogenic cyst lining is a complication very commonly seen in which cyst? Among the choices, எந்த cyst இருந்து carcinoma வரதுக்கு chances ரொம்ப அதிகம்? Is it the dentigerous cyst, OKC, lateral periodontal cyst, or the radicular cyst? Again, right answer is dentigerous cyst. Many of you have given the correct answer. Dentigerous cyst has very important complications. Okay. Cyst lining of dentigerous cyst can give rise to ameloblastoma. Very common. We know that ameloblastoma is a common complication of dentigerous cyst. So that is a benign tumor. Okay. But dentigerous cyst lining can also give rise to malignancies. Very commonly, squamous cell carcinoma can arise from the dentigerous cyst. Sometimes even the mucoepidermoid carcinoma can arise from the dentigerous cyst lining. If it is showing a mucous metaplasia also, you can have a mucoepidermoid carcinoma arising from the dentigerous cyst lining. So, idellam possibilities from the dentigerous cyst. Rest all cysts are not so commonly associated with carcinomatous changes. Okay. Okay. A microscopic feature of which of the following lesions in some areas resembles that of a mucoepidermoid carcinoma? In other words, the 4 choices the lesion has a resemblance of a mucoepidermoid carcinoma. That is, mucoepidermoid carcinoma histopathology you should be aware of. It has both mucous cells and squamous or epidermoid cells will be seen in mucoepidermoid carcinoma. So in the lesion, you can have both of these. If you understand this, mucoepidermoid has both mucous cells and epidermoid cells, you can take a very educated guess and give a correct answer. Yeah, couple of you have given the correct answer. Dr. Satish. Yes, someone iPhone 6s Plus. Yeah, it is cyalo-odontogenic cyst. Dr. Fascia Bono also has given the correct answer. Cyalo-odontogenic. Cyalo refers to salivary gland. Okay, so cyalo-odontogenic cyst nale, that shows that that particular cyst has features of a salivary gland. Salivary gland features nale, we think of a mucus cells. Okay, so in the particular cyst lab, you have both mucus cells as well as the epithelial cells. So it can resemble a mucoepidermoid carcinoma. Cyalo-odontogenic cyst is also called as the glandular odontogenic cyst. Okay, so this glandular odontogenic cyst or a cyalo-odontogenic cyst can resemble a mucoepidermoid carcinoma histopathologically. A very simple question, but many of you make mistakes in this particular question. Which is the most common odontogenic tumor? Yes, which is the most common odontogenic tumor? Ameloblastoma or odontoma? I am sure you can eliminate pinbar tumor and AOT. Is it ameloblastoma or is it odontoma? Which is the most common? Most of you have given the choice as ameloblastoma. In fact, the most common odontogenic tumor is odontoma. Please remember this. Very simple question. You can easily score 4 marks, but most of you will end up with a -1 because you make this mistake. Ameloblastoma is the second most common. Okay, most common is always the odontoma. Choice la odontoma illana, then you go for ameloblastoma. Otherwise, odontoma is always the best option. It is the most common odontogenic tumor. Odontogenic tumor la odontoma ka apramada ameloblastoma is common. Okay. Okay, mixed radio-opaque radiolucent appearance is seen which variant of ameloblastoma? Now, this mixed radio-opaque radiolucent appearance we see in many types of lesions, but in the lesion la ameloblastoma you will find this sort of an appearance. Yeah, the answer is a desmoplastic variant. Usually, ameloblastoma will think of a multilocular radiolucency or single unilocular radiolucency in a unicystic ameloblastoma. But desmoplastic variant or variant where there is thick amount of collagen formation. In the collagen formation, because it is very thick, sometimes there can be dystrophic calcification within that collagen fibers, and that can give a mixed radiolucent radio-opaque appearance. Okay, again, another straightforward question. Only true neoplasm of cementoblast. Cementoblast, there is only one single true neoplasm of cementoblast. Which is that? Which is the only true neoplasm of a cementoblast? Any options, anyone? Yeah, it is the cementoblastoma. Okay, cementoblastoma is the only neoplasm that can arise from cementoblast. Mathabadi, the other lesion, cementoma, cementoosseous dysplasia, is not originating from the cementoblast. Okay. Okay, this again, I think we have discussed already. Pinborg tumor or calcifying epithelial odontogenic tumor. The radiographic appearances, yeah, it is the driven snow appearance. Sunburst appearance we already saw in osteosarcoma. Onion peel appearance can be seen in a Gares osteomyelitis, can also be seen in an osteosarcoma. Cherry blossom appearances, the radiographic appearance in a Sjogren syndrome. Okay. Okay, the next two questions, just observe the question. Okay, why I have put this question is because this is based on the new WHO classification of odontogenic cyst and tumor. Okay, there is something called as a primordial odontogenic tumor, which is a very new entity. It is a benign tumor of mixed epithelial and connective tissue origin. It has a dental papilla-like connective tissue covered by a ameloblastic epithelium. It is a new entity involved in the or introduced in the new WHO classification of 2017. Okay, so just remember there is a new lesion called as a primordial odontogenic tumor. Okay, பழைய textbook or 2 years முன்னாடி இருக்கிற textbook probably you might not have this lesion that has been described. Okay, again WHO 2017 classification there are 3 new entities that have been introduced. One, we saw the primordial odontogenic tumor. Secondly, there is something called as a odontogenic carcinosarcoma. Okay, this is also a new tumor that has been introduced in the 2017 classification. Then you have something called as a sclerosing odontogenic carcinoma. Again, a new lesion that has been introduced in the 2017 classification. Just remember these 3 new entities and remember what type of lesion the primordial odontogenic tumor is. Okay, so you can have a question because it is a newly introduced entity. You can have a question on this also. Okay. Next, let us go to salivary gland pathology. Just a few questions on salivary gland lesions. Okay. Again, starting with a very simple and straightforward question. Plunging ranula or cervical ranula occurs when the mucin dissects between which muscle? Okay, ranula is basically a mucosal of the sublingual salivary gland. Sometimes the ranula can be seen in the neck, outside of the neck and it can be seen. That is called as the plunging ranula or the cervical ranula. That happens because the mucin, accumulated mucin will spread through the mylohyoid muscle. It will split the mylohyoid muscle and it will go and it will get accumulated in the submandibular region. So this is called as a cervical ranula or a plunging ranula. Okay, again, another slightly tricky question because of the wordings. Submandibular gland is the most common location for which of the following pathology? Mucosila, Sjogren syndrome, sialolithiasis, necrotizing sialometaplasia, which commonly occurs in the submandibular salivary gland. Yeah, again, most of you have given the correct answers. Sialolithiasis. Sialolithiasis is common in the submandibular gland. Mucosal is very common in the minor salivary glands of the lower lip. Okay, Sjogren syndrome is common in the parotid glands. Necrotizing sialometaplasia is common in the minor salivary glands of the palatal region. Okay. Parotid fatty change is a classic sign can be seen in which of these conditions? If you have observed many of the individuals, you will give a correct answer. Okay. Yeah, some of you have given the correct answer. It is alcoholism. Nare alcoholic patients, chronic alcohol users, they'll have enlargement in the near the ear, around the ear. In the parotid region, it will appear more chubby and enlarged. That is mainly because there is a fatty change in the parotid gland that gives that sort of an appearance. A very typical feature of chronic alcoholism. Okay, Bell's disease. This is another named entity. Bell's disease is also known as which of the following lesions? Bell's disease. Okay, Sutton's disease. I mean, there are two named lesions, Bell's disease and Sutton's disease. These are basically a type of enlarged inflammatory swelling of the minor salivary glands of the lower lip. Okay, we call it as cheilitis glandularis. Cheilitis glandularis, you will find that you can have a suppurative type and a non-suppurative type. Suppurative type, superficial suppurative type and deep suppurative type. Okay, superficial we call it as a Bell's disease. Deep suppurative type we call it as a Sutton's disease. Sutton, Sutton's disease. Okay, so basically these are inflammatory swelling of the minor salivary glands of the lower lip. Okay, which is false about the Sjogren syndrome? Primary Sjogren is also called as Sika syndrome. Elevated rheumatoid factor is found, most commonly seen in males. Salivary gland shows presence of epimyoepithelial islands, which is not true about the Sjogren syndrome. Any answers? Anyone guessing any answers? Yeah. Okay. Some of you have given a correct answer. Most commonly occurs in males, not true. Most commonly occurs in females. Okay. Detailed explanation but always remember that autoimmune diseases have a higher incidence in females. In general, any autoimmune disease, most of the autoimmune diseases have a higher likelihood of occurring in females rather than males. Okay, Sjogren syndrome, it is more common in females than in males. Okay, xylographic appearance. Okay, normal salivary gland, xylographic appearance. What type of appearance we expect in a normal salivary gland? Yes. Yeah, you have what is called as a leafless tree appearance. Okay, normal xylographic and the contrast medium, if you are going to inject into the duct of a salivary gland, the xylographic medium, the medium should extend only to the ducts. Wherever the duct is present, only the duct will be seen in the xylography. Okay, so it appears like a leafless tree appearance. Okay, either way, Sjogren syndrome in the leafless tree kuda, you will have lots of small accumulations within the salivary gland parenchyma also. So that is called as a fruit-laden tree appearance, branchless fruit-laden tree appearance. Okay, so this is seen in Sjogren syndrome. Sausage string appearance, you see it in cyanodoctitis, that is inflammation and constriction of the salivary gland duct. Okay, so that gives a sausage string appearance. Sausage string Google search you will get an idea. Okay, sausage on the ground meat nalla grind pannittu chinna long tubes they make it and then they tie it and they use it in hot dogs in the mari. Okay, so adla type பண்ற இடத்துல that meat will be very thin and constricted. Okay, so that sort of an appearance you find it in salivary duct inflammation and scarring. So that is called as a sausage string appearance. Ball in hand appearance is generally seen in a space occupying lesion. Okay, lesion edavadhu or period tumor edavadhu irundu salivary duct edavadhu, if it is going around that tumor, you have this ball in hand appearance. Okay, pleomorphic adenoma. If you remember the histopathology of pleomorphic adenoma, you have chondroid areas, osseous areas. Okay, in the mari different types of appearance you can see in the histopathology of a pleomorphic adenoma. In the mesenchymal appearing, the chondroid areas, osseous areas, it is produced by a single cell. Which cell produces all these structures? Yes, again, many of you have given the correct answer, myoepithelial cell. That is why this particular lesion is called as a false mixed tumor. Okay. Why it is called as a false mixed tumor is, even though there are so many epithelial component and chondroid, osseous, in the mari connective tissue components irundhalum, all these epithelial and connective tissue components are produced by a single cell, that is the myoepithelial cell. So it is called as a false mixed tumor. True mixed tumor la epithelial component to malignant neoplastic connective tissue component to neoplastic that is seen only in teratomas. Okay, so not in pleomorphic adenoma. Okay, which cell in mucoepidermoid carcinoma is believed to be a progenitor for both mucous as well as epidermoid cell? So I already mentioned mucoepidermoid carcinoma, you have mucous cells and you have the epidermoid cells. Both these cells are thought to arise from another type of cell. Okay, that type of cell is, yeah, it is the intermediate cell. Okay, reserve cell kadayadu. Intermediate cell is thought to give rise to both the mucous type of cell as well as the epidermoid type of cell in mucoepidermoid carcinoma. Okay. Okay, another direct straightforward question. Common salivary gland tumor in children. Is it lymphoma, pleomorphic adenoma, adenoid cystic carcinoma, or mucoepidermoid carcinoma? In children, it is the mucoepidermoid carcinoma. In adults, it is the pleomorphic adenoma. In children, it is the mucoepidermoid carcinoma. Okay. Next, going on to bone pathology. I think I'll have to rush a little. Okay. Please bear with me. Okay. Osteogenesis in developmental disturbances also. Osteogenesis imperfecta arises due to improper collagen formation. So which type of collagen is disturbed in osteogenesis imperfecta? Is it the type 1, type 2, type 3 or type 4? In the mari doubtful on questions vanda, if you really want to make an attempt, always go for type 1. Okay, type 1 is seen in most of the body structures. Okay, osteogenesis imperfecta, you know, it affects most of the body structures. Bone, sclera, connective tissue, ellame affect agum. And most of the body structures have collagen. 96% of the body collagen is made up of type 1 collagen. Okay. But the types of collagen, type 2, type 3, type 4, ellame very specific and found in very few areas. For example, type 4 collagen is found in the basement membrane. Okay. So in the very specific areas, the types of collagen irukku. So in the question, if you don't know the answer and still if you want to give an attempt, see whether the lesion is going to be distributed throughout the body. If the lesion or disease is distributed throughout the body, go for a type 1 collagen. Okay. Okay, pale blue sclera, we saw that it is seen in osteogenesis imperfecta. In the condition la irukadu. Okay, pale blue sclera is not exclusive to osteogenesis imperfecta. Mattume irukun kediyadu. It can be seen in many lesions. So in the lesion la pale blue sclera irukadu. Any guesses? Okay, it is Peary-Robin anomaly. Some of you have given this answer, Peary-Robin anomaly. I have mentioned already Peary-Robin syndrome. It is because of micrognathia. Micrognathia, glossoptosis nala cleft palate. Okay, that is not related to any collagen defect. Okay, whereas Paget's disease, Marfan syndrome, Ehlers-Danlos syndrome, all are connective tissue disorders involving the bone and the collagen. So in all these conditions, you can have pale blue sclera. Okay. In addition, osteogenesis imperfecta, pale blue sclera irukum. Okay. Okay. Characteristic skeletal defects like arachnodactyly, dolichostenomelia, hyperextensibility of joints. In the syndrome la irukum. I think I have mentioned this already. Arachnodactyly means spider-like fingers. Arachno refers to spider. Arachnodactyly means spider-like fingers, long fingers. Dolichostenomelia is when the limbs are very long compared to the general body. Okay. And hyperextensibility of the joints. These are typically seen in, yes, correct, Marfan syndrome. Okay. Marfan syndrome la arachnodactyly irukum, dolichostenomelia irukum, hyperextensibility of joints irukum. Oral cavity there will be an abnormal highly arched palate will be seen in Marfan syndrome. Okay, hypophosphatasia is because of lack of which enzyme? Oral manifestation hypophosphatasia there will be improper or lack of cementum formation, so there will be early loss of teeth. Okay, premature exfoliation of teeth will be seen in hypophosphatasia. It is because of, yes, most of you are correct. It is because of a lack of the alkaline phosphatase enzyme. Okay. Okay. Again, this I think all of you will be able to answer correctly. Hereditary condition, non-neoplastic bone lesion, histologically similar to giant cell granuloma, affects the jaws of children bilaterally. Typically seen in, yes, all of you are correct. It is seen in cherubism. So cherubism, very typical explanation is that it is a hereditary condition. It occurs in subsequent generations also. Histopathological, it is a giant cell granuloma. There will be multiple giant cells. Both the jaws will be affected bilaterally. Okay, especially the maxilla and sometimes the mandible also. Okay, you will have, it is a non-neoplastic lesion. Okay, eyes upturned towards the heaven. That sort of an appearance will be there. Cherubic appearance or angelic appearance of the face will be there. So that is a typical feature of cherubism. Okay, which of the following histological features is found in Paget's disease? Paget's order, classical histological feature and failure of endochondral ossification, failure of fibroblastic maturation, abnormal and excessive remodeling of bone, or abnormal collagen maturation. I think again all of you are correct. Paget's is because of abnormal and excessive remodeling of bone. Okay, so there will be some amount of bone formation. Stop at Marbin, there will be bone resorption. Again, a stop at bone formation. So in the Mari, alternate resorption and bone formation, alternate continuous and another tear canal. Histologically, you will be able to find prominent reversal lines. Okay, that is a typical feature of Paget's disease. Prominent reversal lines will be seen. And you have a mosaic pattern because these reversal pattern lines or mari mosaic or a haphazard wavy lines it gives a mosaic type of appearance histologically. Okay, so those are the typical features of Paget's disease. Okay, basic disturbance in osteopetrosis. We saw osteopetrosis also called as a marble bone disease or Albers-Schonberg disease. The basic defect in osteopetrosis is இதுல பாத்தீங்கன்னா ரேடியோகிராஃப் பாத்தீங்கன்னா medullary space இருக்காது. The entire bone appears to be made up of cortical plate alone. Thick radio opaque bone will be seen and bone will become very very brittle. Medulla இல்லாதனால bone cannot withstand even mild trauma. Even a mild trauma will result in fracture of bone in multiple locations. So the typical feature என்னன்னா there is lack of osteoclastic activity. Bone remodeling நடக்காது. Because there is no osteoclastic activity, medullary space will be gradually filled with the bone completely and there won't be any medullary space at all. That is the typical feature of osteopetrosis. Okay, again a couple of slides for taking screenshots. Okay, different radiological patterns and histological patterns. Okay, just take a screenshot of this particular slide and go through it later on. Okay. Okay, so we have just 2 more sections. I think I might extend my time beyond 1 o'clock, probably another 10 minutes beyond 1 o'clock. Okay, so we'll just see skin lesions and then a mixed of other topics, miscellaneous topics we'll have to see. Okay, now this is a very straightforward question. Flat circumscribed discoloration of the skin. What is that lesion called as? Okay, is it the epulis, macule, nodule, or papule? Again, all of you are correct. It is the macule, a pigmented discoloration of a skin that is not elevated. You call it as a macule. So be aware of all the different terms: epulis, nodule, papule, vesicle, bulla. All these lesions, go through the definitions of all these terms. You might have a direct question like this sometimes. Okay, in hereditary ectodermal dysplasia, which of the following structure is not affected? Okay, this is a very simple question if you think and answer. Okay, hereditary ectodermal dysplasia. So it means that structures that are derived from the ectoderm are going to be affected by this particular condition. So ectodermal derived structures, enamel is derived from the ectoderm, hair is derived from the ectoderm, sweat glands are also derived from the ectoderm. Bone is not ectodermal in origin. Bone is mesodermal in origin. So bones are not affected in hereditary ectodermal dysplasia. Enamel, hair, sweat glands will be affected. Patient will be having very sparse hairs. Sweating will be absent. Okay, adanala there will be intolerance to heat. Okay, oral cavity multiple missing teeth, and இருக்கிற teeth will be conical shaped. Okay, so that is a very typical feature of hereditary ectodermal dysplasia. Okay, again about lichen planus, which is not correct. It is a T cell mediated autoimmune disease, B cell mediated autoimmune disease. Vicam stria are seen, most commonly seen on the buccal mucosa, which is not true about the lichen planus. So it will obviously your choice is either between A or B. Either it is a T cell mediated or it is a B cell mediated. So ideally it is a T cell mediated disease. So B cell mediated disease is the wrong choice. Okay, so it is a T cell mediated disorder. Vicam stria are seen in the buccal mucosa or in the lesions of the oral cavity, and very commonly bilaterally in the buccal mucosa you can have this lichen planus lesions. Okay, Auspitz sign and Monroe's abscess. எந்த lesionல இருக்கும்? Auspitz sign and Monroe's abscess.
Psoriasis.
Yeah, again many of you have given correct answer, that is psoriasis. Okay, Auspitz sign என்னன்னு பாத்தீங்கன்னா, when you try to take out a scale, when you try to pull out a scale, there will be a small bleeding spot. That is the Auspitz sign. Monroe's abscess is nothing but a small abscess, accumulation of neutrophils within the epithelium. Epithelium intraepithelial neutrophilic abscesses are called as the Monroe's abscess. Both are very typical features of psoriasis. Okay, again I think all of you might be aware of Nikolsky sign. Nikolsky sign and probably. Okay, when you give a lateral pressure on clinically unaffected mucosa or skin, that particular region will show a vesicle formation, or the skin in that particular region will shear out. Okay, so that is Nikolsky sign, and that is mainly because of, okay, most of you have given it as because of subepithelial split. Nikolsky sign is not because of subepithelial split, it is because of prevesicular edema. Remember this, vesicle முன்னாடி அந்த இடத்துல edema formation, intraepithelial edema இருக்கும். So that will make the epithelial cells weak. Okay, so இந்த மாதிரி weak epithelial cells இருக்கும்போது, when you apply a lateral pressure, easily the epithelial cells will separate from each other and there will be a vesicle that is formed in that particular region. So that is why you get this positive Nikolsky sign. It is because of prevesicular edema and not because of subepithelial split. Okay, in the vesiculobullous disease lab, you have decreased vision, blindness, prominent scarring and airway obstruction. One of the following vesiculobullous diseases has very aggressive in its clinical appearance and clinical symptoms. Okay, you can have decreased vision, blindness over a period of time, scar formations and airway obstruction also can be seen. In which type of vesiculobullous lesion can you find all these conditions? Okay, mixed answers, but the correct answer is a benign mucous membrane pemphigoid. Okay, benign mucous membrane pemphigoid, as the term indicates, it affects the mucous membranes. Okay, so conjunctiva of the eye can be affected, the oral cavity can be affected, the mucous membrane of the respiratory and the pharyngeal mucosa can be affected. In the mari lesions regions, there can be vesicle formation which can rupture and result in scar formation. So when it affects the eye, there can be decreased vision and blindness. When it affects the pharynx or the larynx, you can have airway obstruction also. So this is a very severe condition. Okay, it's a benign mucous membrane pemphigoid. Okay, which of the following disease, hereditary skin disease? Questionly, you have a clue. It is a hereditary skin disease. It occurs in response to mechanical trauma or irritation. Which is the lesion? Epidermolysis bullosa, pemphigus, SLE or cicatricial pemphigoid? Which of these is hereditary? It can occur, lesions can occur due to mechanical trauma or irritation. Any choices? Okay, the correct option is the epidermolysis bullosa. Okay, epidermolysis bullosa is a hereditary condition. It can be transmitted from generation to generation. You will find lesions that arise as a response to trauma or irritation. So elbows edaad keela support panni vechirundha odane and the elbow region la you can have vesicles. Okay, child because the child is crawling, wherever the child is touching the floor and the region la you can have vesicle formation. So that is very typical of epidermolysis bullosa. Rest of the lesions are autoimmune, but they are not hereditary in nature. Remember that. Okay. Autoimmune is different. Hereditary is different. Okay. Corbnus phenomenon is seen in which of these following conditions? You should know what is Corbnus phenomenon. Corbnus phenomenon, again, wherever there is a trauma and the particular region lesions pudusa varum. That is called as Corbnus phenomenon. So this is again seen in psoriasis. Okay, it is a condition that is seen in psoriasis. We already saw that it can occur in erythema, epidermolysis bullosa. So in addition to epidermolysis bullosa, Corbnus phenomenon can be seen in psoriasis, can be seen in lichen planus, Kaposi sarcoma, SLE, and cutaneous leishmaniasis also. So basically, Corbnus phenomenon, skin lesions occur wherever there is injury. That is the Corbnus phenomenon. Very typically seen in epidermolysis bullosa, can be seen in psoriasis and lichen planus also, and also in few other lesions. Okay, scleroderma, which is true. Tightening of oral mucosa and periodontal involvement, multiple palmar keratosis, Raynaud's phenomenon, all of the above, which is true. Yeah, again, correct answers from all of you. All are correct. Okay, oral mucosa will appear tightened, so almost resembles the oral submucous fibrosis in the oral cavity. Periodontal involvement will be there, so there will be a widening of the periodontal space in scleroderma. Multiple palmar keratosis and Raynaud's phenomenon will also be seen. Raynaud's phenomenon, when you immerse the hands in the cold water, you will find a change in the color of the hand. It will become white. When you take the hands out, it becomes more bluish and then reddish in color. And there will be change in the color of the hands. That is typical of Raynaud's phenomenon. Okay, again, screenshot time. Take a screenshot of the different signs that are associated with some of the oral lesions. Nikolsky sign, Auspitz sign, Higomenaki sign, Trousseau sign, Chostek sign. இதெல்லாம் என்னென்ன lesions-ல இருக்கும். Just have a note of all this signs. Okay, take a screenshot. Okay, lastly, coming on to the other topics. I think time is okay. We have another 10 minutes, probably 10 to 15 minutes I'll take, and I'll finish off the entire topics. Okay, so this is the last section. This is just a mishmash of all the other topics that we have not covered so far. Okay, so characteristic tramline calcification skull radiograph can be seen in which disease or syndrome? I think this we have discussed already. Yeah, it is seen in Sturge-Weber syndrome. Sturge-Weber syndrome, port vein stain will be there, and then you can also have tramline calcifications. Tramline calcification, two parallel calcification. Yeah, Vardhana, the sulci and gyri. Okay, you have in the brain, you have the sulci and the gyri. In the mari folds nariya irukum. So in the mari region la calcification irukanaala, you can have a tramline sort of an appearance. Okay, so that is a characteristic feature of a Sturge-Weber syndrome. Okay, about trigeminal neuralgia, which is true. Paralysis of one side of the face, uncontrollable twitching of the muscles, sharp excruciating pain of short duration, prolonged episode of pain on one side of the face, which is true. Yeah, again, all are correct answers. It is a sharp excruciating pain that is seen on for a very short duration, usually on one side. Okay, you have what are called as the trigger zones anywhere along the course of the involved nerve, that is the trigeminal nerve. It can be the ophthalmic branch or the maxillary branch or the mandibular branch. In the branch involved ayirukko, and the branch along the course of the nerve, there will be certain trigger zones, and the trigger zones lesa tottale, there will be a very sharp and excruciating pain of very short duration that almost traces throughout the course of that particular nerve. Okay. So which is false about this trigeminal neuralgia? We saw what is true. It is a sharp and excruciating pain. Which is false? Affects females more than males. Affects the left side more than right side. Tumors or aneurysms are one of its causes. Older adults are more frequently involved. Which is false? Idhula vandu moonu factors vandu true. Okay, again, a mix of answers I'm getting. What is not true is that usually trigeminal neuralgia, for some unexplained reason, it has a tendency of affecting the right side more than the left side. Okay, we don't know what the reason is. Trigeminal neuralgia has a tendency to affect the right side commonly than the left side. Rest all are true. Females are more commonly affected than males. Various causes. One of the proposed causes is that there is some tumor or aneurysm near the trigeminal ganglion. அதனால trigeminal neuralgia வருதுன்னு சொல்றாங்க. Okay. And it is more common in older adults greater than 40 or 45 years of age. You have a higher incidence of trigeminal neuralgia. Remember, it has a greater tendency for affecting the right side of the face rather than the left side. Okay. Clinical condition similar to trigeminal neuralgia called post-herpetic neuralgia occurs after which infection? Chickenpox, herpes zoster, herpes simplex, herpes angina. Following which infection? Observe the question carefully and give the correct answer. Yeah, it is herpes zoster infection. Following herpes zoster infection. Okay. Herpes zoster, it is a reactivated chickenpox. Okay, varicella zoster reactivated achina, we get herpes zoster. Herpes zoster apparama, after this herpes zoster infection, the patient will be having this sort of a neuralgia called as the post-herpetic neuralgia. Very, very painful. Whichever dermatome was involved in the herpes zoster infection, that dermatome usually shows this post-herpetic neuralgia also. Okay. Okay, so this I have discussed already in developmental disturbances. Okay, when we saw one of the choices. Frey syndrome is a result of damage to which nerve? I think all of you are giving the correct answers. It is because of involvement of the auriculotemporal nerve. Normal parasympathetic fibers to the salivary glands will pass through the auriculotemporal nerve, and auriculotemporal nerve will give the parasympathetic stimulation to the salivary glands. When there is a trauma to the auriculotemporal nerve, this parasympathetic fibers will, instead of the salivary gland, it will get innervated to the sweat glands. So whenever the patient is having some food during the meal time, salivary secretion அதிகமாகிறதுக்கு பதிலா sweat secretion அதிகமாகும். So that is the Frey syndrome or the auriculotemporal syndrome. Okay, most common neurological disorder of cranial nerves: trigeminal neuralgia, sphenoparietal neuralgia, glossopalatal neuralgia, or Bell's palsy. Which is the most common neurological disorder of the cranial nerves? Yeah, some of you have given the correct answer. Very easy to mistake and call trigeminal neuralgia as most common, but trigeminal neuralgia kadayadu. Most common is always the Bell's palsy. Very, very, very common. Okay, Bell's palsy is the most common neurological disorder of cranial nerve. Adukapram da trigeminal neuralgia. Okay, so be aware of this particular frequency distribution. Okay. Okay, metastatic calcification is most commonly seen in which condition? Hyperkalemia, hyperparathyroidism, osteoporosis, or pulp stone. எதுல metastatic calcification இருக்கும்? Yes, metastatic calcification can be seen in hyperparathyroidism. Calcification can be of two types. You can have a dystrophic calcification, you can have metastatic calcification. Dystrophic calcification happens in dead tissues, and it happens when the calcium levels are normal in the blood. Metastatic calcification can occur even in living tissues. It happens only when there is an increased calcium level in the blood. That happens in hyperparathyroidism. Okay. Special stain for amyloid. Which is the special stain to demonstrate the amyloid material? Any guesses? Yes, it is the Congo red stain. Congo red stain panittu, we see it under the polarizing microscope. It gives a apple red birefringence. Apple green birefringence will be seen in the case of amyloid. Okay. So the periodic acid shift is used to stain carbohydrates. Okay. Basement membrane, you will be able to see this periodic acid shift stain positivity. So PAS is used for staining the carbohydrates. It is used for basement membrane identification. It is also used for identifying hyphae of fungi. Okay. Pulse Prussian blue is used to identify iron. Alcian blue is used to identify the mucin. Okay. Salivary gland secretions identify பண்றதுக்கு Alcian blue. PAS is used for carbohydrates. So used for identifying basement membrane and the candidal hyphae or fungal hyphae. Pulse Prussian blue for iron. and Alcian blue for the mucin deposits. Okay, reddish or brownish pigmentation of all the teeth along with photosensitivity and excretion of reddish colored urine, very typically seen in which disease? Okay, in the condition on the very unique. Yeah, all of you have given the correct answer. It is the congenital porphyria. There is some abnormality in the porphyrin metabolism. Porphyrin is basically a component of the hemoglobin. So the porphyrin metabolism normal abnormal agumbodhu, you will have excessive deposits of the porphyrin in many parts of the human tissue. One is the dentin. Okay, dentin pulp there will be lots of accumulation of this porphyrin rings and tissue material. So that results in a reddish or brownish or amber colored teeth appearance will be seen in the case of congenital porphyria. Okay, this is a straightforward question. Biopsy which serves as a treatment option. Punch biopsy, incisional biopsy, FNAC or excision biopsy. Yes, all of you have given the correct answer. That is the excision biopsy. Okay, excision biopsy is also the treatment. Okay, especially done in very small lesions which are less than 1 centimeter in diameter. Even if you suspect a malignancy, in the chinna lesions are it is always better to go for a excision because that will be a single surgical procedure that will be the biopsy diagnostic purpose as well as the treatment purpose for the patient. Okay, site where recurrent aphthous ulcer does not commonly occur. Okay, aphthous ulcers, it has very common locations in the oral cavity. Yenga commona nadakadu, where it does not happen. Yes, wherever there is a tightly bound mucosa. Okay, that is the masticatory mucosa. Gingiva and hard palate are not affected by the recurrent aphthous ulcer. The labile mucosa like labial mucosa, tongue, soft palate, recurrent aphthous ulcers. The opposite happens for herpes stomatitis. Herpetic stomatitis, you will find that the gingiva and hard palate are commonly affected. Labial mucosa, tongue, and they are very less commonly affected. Okay, so aphthous ulcers only in the movable mucosa. The herpes lesions are more common in the attached mucosa, that is the gingiva and hard palate. Okay, healing of which of the following regions in the oral cavity is most likely occurring by secondary intention? Again, a straightforward question. You must be knowing healing can occur by primary intention or by secondary intention. Primary intention when both the margins of the wound can be easily opposed to each other. Secondary intention when they cannot be opposed to each other. Okay, so that happens in the palate. Palate, because it is a tightly bound mucosa, without chinna lesion irundalum, you find that it is very difficult to bring the edges of the lesion together and suture it. Okay, so always palatal lesions heal by secondary intention. Okay, dry socket or alveolitis sicca, it is essentially what type of osteomyelitis? Acuta, chronica, garesa, focal osteomyelitis. Dry socket. Okay, dry socket is also a type of osteomyelitis. Okay, you can mistake it for an acute osteomyelitis, but most appropriate is that it is a focal osteomyelitis. Or chinna focal localized area in the osteomyelitis irkarnala, it is better to go for a focal osteomyelitis rather than calling it as a acute osteomyelitis. Okay, so focal osteomyelitis is going to be the most appropriate description there. Okay, when a tooth is avulsed, it is important to reduce the extraoral time. For what reason? Okay, tooth avulsachna, you usually try to re-implant the tooth in the same location, in the same socket. So the extraoral time should be minimized. That is because, yeah, you have to keep the cells of the pedal in the viable state. Only then the tooth will properly attach to the underlying bone through the formation of the periodontal ligament. Otherwise, there will be either ankylosis or external resorption, and there will be failure of the re-implantation. Okay, osteoradionecrosis is characterized by all of the following except osteoradionecrosis la edu irukadu. Secustum, involucrum, hypovascularity, hypocellularity, which is not seen. Yes. Yeah, it is involucrum. Okay, involucrum na newborn formation. Osteoradionecrosis, there won't be any newborn formation. It is a completely destructive lesion. Due to radiation, there will be decreased vascularity, that is hypovascularity. Due to radiation, decreased cells, osteoblast ellame kammi agum, that is hypovascular cellularity. And because of this, sometime if there is a trauma, cells kammiya irukku, vascularity kammiya irukkarnala healing nadakadu. There will be necrosis, that is the osteoradionecrosis. So you will have cecostrum formation. Okay, there won't be any newborn formation. Okay, radiation carries begins in which location? Incisal surface, subcallosal plate, cervical region, or the smooth surface? Where does the radiation carries begin? Most of you have called it as a smooth surface. Typically, radiation carries occurs in the cervical region, the neck of the teeth. That is the typical location where the radiation carries begins. Okay, where it begins in the ketirukanga, it begins at the cervical region very, very typically. Okay. Okay, thin blue-black line in marginal gingiva. It is seen due to poisoning of bismuth, silver, gold, or mercury. In the poisoning, the blue-black line is seen in the marginal gingiva. Okay, it is seen in the bismuth poisoning. Okay, bismuth poisoning, you have the thin blue-black line in the marginal gingiva. Lead poisoning, again blue-black line. It is called as the Burtonian line. Silver poisoning, you have a gray blue generalized pigmentation. Okay, argyrila, you have a generalized pigmentation, not a linear line like appearance irukadu. Instead, there will be a linear, macular pigmentation in the case of silver poisoning. Okay, just last couple of questions. Traumatic bone cyst, which is not correct. Most commonly occurs in the mandible, appears as a well-defined unilocular radiolucency, lined by stratified common epithelium, thought to arise due to trauma, which is not correct in traumatic bone cyst. So if you know what is the type of cyst, yes, it is a pseudocyst, it is a false cyst. So it does not have any epithelial lining. It occurs in the mandible, unilocular well-defined radiolucency. It occurs due to trauma and degeneration of the clot, but it does not have any lining. Okay. Okay, whitish or reddish erosive or ulcerative erosions in the marginal and attached gingiva in canine and premolar region, most likely due to canine and premolar region la marginal gingiva la ulcerations or superficial erosions irukana, most commonly due to toothbrush trauma. You have to suspect toothbrush trauma first, then you have to think of other diseases. Okay. Most sensitive to ionizing radiation, which type of cell? Germ cell, developing bone cell, salivary gland, pancreas. I think again this is a very straightforward question. Cells that are having the ability to proliferate very easily are most sensitive to radiation. So it is going to be the germ cells. Okay. Etiology of angioedema. Is it due to sensitivity to resins or any dental materials? Using ACE inhibitors, hereditary, all of the above. Okay. So angioedema pathina, sudden edema or swelling in the facial tissues. It occurs as a result of any of the above factors. So all of the above can be the etiology of angioedema. Okay. Internal resorption, what is the characteristic feature? Pain on percussion, slow pain, no characteristic feature, increased pain while lying down. Yes, again, most of you have given the correct answer. There won't be any symptom in the case of internal resorption. Sudden pinkish discoloration of the tooth should give you a clue that it is an internal resorption. Okay. Erosion is irreversible loss of tooth due to a chemical process that does not involve what? Microorganism, acid, saliva, or none of the above. Erosion la acids involvement irukum. What is the difference from caries is that erosion does not involve the microorganisms, whereas caries involves the microorganisms. Okay. Okay, again, which is true? Different types of lesions in different deficiencies. Okay, strawberry tongue is seen in which condition? Molars clausitis is seen in which condition? Hunter's clausitis in which condition? Ball tongue or sandwich in which condition? This is the correct match. Molars clausitis is seen in pernicious anemia. That is the correct option. Okay. Strawberry tongue is seen in scarlet fever. Okay. Hunter's glossitis is seen in pernicious anemia. Ball tongue of sandwich is seen in pellagra. Okay, so strawberry tongue, scarlet fever. Hunter's glossitis or Moller's glossitis is seen in pernicious anemia. Ball tongue of sandwich is seen in pellagra. Okay, teeth floating in air appearance is seen in which condition? Hyperparathyroidism, hyperthyroidism, eosinophilic granuloma, or hypothyroidism. Usually teeth floating in air appearance, we use the term in cherubism. Adilama barur conditionally, you can have this tooth floating in air appearance. Yes, some of you have given the correct answer. It is seen in eosinophilic granuloma also. Okay, basically multiple teeth, bone destruction. So that is a tooth floating in air appearance. Okay, so now these are a couple of questions which I told earlier. Case-based questions, illa picture-based questions. Okay, now this is an example of a picture-based question. Typical of this sort of an appearance which is seen in the picture. What lesion you have, this sort of an appearance. So the lesion enna abdingiradhu you should know. These are what are called as the bullseye lesions. Small erythematous lesions appearing as concentric rings. That is typically seen in erythema multiforme. One form of erythema multiforme is the Stevens-Johnson syndrome. So the correct answer is the Stevens-Johnson syndrome. Okay, so this is the correct answer. Again, many of you have given the correct answer. Okay, in the slightly indirect question, they will give you the lesion. They won't ask you what is the lesion. They will ask you what is the etiology for that particular lesion. Okay, so this particular lesion, first identify pannu. Okay, so this lesion, what you see here is the hairy leukoplakia, oral hairy leukoplakia, which is very commonly seen in HIV patients. Now you have to think what causes this oral hairy leukoplakia. Some of you have given the correct answer. This oral hairy leukoplakia is because of Epstein-Barr virus infection and not HHV or HIV. Okay, so in the slightly indirect picture questions, chances. You can have a question like this also. You can be given a radiograph and you can be asked to interpret what is the correct answer. So in the OPG, it can be any of the following except what in Kekrang. So think and see the OPG. You are able to see a radiolucency. That radiolucency is well-defined radiolucency. You are able to see a radio opaque border also in some regions. Okay. So having all these points in mind, you see whether it can be a dentigerous cyst. It can be a dentigerous cyst. Impacted tooth illa, but still it could be a dentigerous cyst associated with this last molar also. Okay. Ameloblastoma irukuma? Yes, it can be an ameloblastoma also. Okay, unicystic ameloblastoma irukadhukku chances irukku. Again, it can be an OKC also. Sometimes OKCs can also be unicystic in appearance. Still, it has a large unicystic radiolucency with radio-opaque borders. Intraosseous carcinoma are not well defined. You don't have such well-defined borders, corticated borders irukadu. So it cannot be a intraosseous carcinoma. Intraosseous carcinoma will be more haphazard and having a jagged borders. Okay, so you should be able to rule out all the other choices and arrive at a correct diagnosis in such type of questions. Okay, so intraosseous carcinoma, it can be any of the other three. Okay, now it can be a case-based question like this. 40-year-old male patient reported to the OPD. Okay, patient is having swollen gums, occasional bleeding from gums chronic gudka chewer or additional information okay, poor oral hygiene okay, now this is based on the clinical history. Okay, 40-year-old patient, swollen gums bleeding from the gums patient is having a gudka chewing habit, patient is having a poor oral hygiene. Now they have taken a routine blood investigation and it shows that the total leukocyte count is 37,000. Okay, remember that. Moderately low amount of platelets irukonu. Now what is going to be your next step? Okay, so you have to take together all the features in such case. Okay, even though they say poor oral hygiene and gudka chewing habit, you cannot suspect a leukoplakia or carcinoma, or you cannot say that it is just a poor oral hygiene associated gingival swelling. Investigation, they have shown that the leukocyte count is 37,000. Normally you have only 4,000 to 11,000. So there's an increased amount of WBCs. They are seeing moderately low platelets. That means the leukocytes are proliferating at a higher rate that the platelet count is becoming lesser. Okay. So then you have to suspect a leukemia first. You have to take a blood investigation to rule out the leukemia. That is how you have to proceed. So in the matter, you have to take into consideration all the features or all the important points that they have given in the question. Take the time to read the question, find out all the points that they have given, and then come to a diagnosis rather than directly jumping. Bleeding gums, poor oral hygiene, prophylaxis அப்படின்னு ஜம்ப் ஆன் பண்ணக்கூடாது. இல்லை குட்கா சுவர் அதனால லியூகோப்ளேக்கியா அப்படின்னு டைரக்டா யூ ஷுட் நாட் சஸ்பெக்ட். ஓகே, டேக் இன்டு கன்சிடரேஷன் ஆல் த ஃபேக்ட்ஸ் தட் தே ஹேவ் given. Okay, this is the last question. Okay, again same, you have a picture as well as you have the clinical history. 36-year-old female சொல்றாங்க, slightly painful mass emerging from the gums. Okay, remember this, emerging from the gums. Okay, slow growth since 8 months, firm, hard, non-tender, and extending from 2.2 to 2.3 region that you can see here in the clinical picture. Okay, so clinical 36-year-old female, slightly painful mass, growth from the gums, slowly growing it is. Okay, firm to hard in consistency, it is not tender, extends from 2.2 to 2.3 region. Histopathological examination, stroma with calcific deposits இருக்குன்னு சொல்றாங்க, osteoid or trabecular pattern இருக்குன்னு சொல்றாங்க, peripheral osteoblastic rimming இருக்குன்னு சொல்றாங்க. Okay, so you are given a histopathology also. So what is the most likely diagnosis? Okay, now for this you have to again take into consideration both the clinical and histopathological features. Okay, now let us go one by one. Pyogenic granuloma. Pyogenic granuloma usually in the mari firm to hard irundalum you don't get the calcific deposits or bone formation in the histopathology. Pyogenic granuloma irukadu. Okay, so you can rule out that. Cemento-ossifying fibroma, yes, it follows all the criteria, it fits into all the criteria, so it could be a cemento-ossifying fibroma. What about pulp polyp? Yes, it can show a growth, but it is associated with a carious lesion. It has to emerge from within the carious cavity, and again it is highly bleeding. Calcification la irukadu, usually pulp polyp la irukadu. Giant cell granuloma, it is usually an intrabony lesion, peripheral central and sollala. Okay, even if it's a peripheral lesion, usually you will find lots of giant cells, but there won't be any bone formation, etc. So the correct option, like many of you have mentioned, it is the peripheral cemento-ossifying fibroma. Okay, so these last 5 questions I mentioned mainly to make you accustomed to these sort of questions also. You will be given pictures, you will be given clinical history. Try to take into consideration all these points and then arrive at a diagnosis slowly. Okay, so that finishes all the questions. I think I have covered all the topics. Just a couple of slides, you can take a screenshot and you can use it for revising later on. Okay, so before concluding, let me tell you, like, I think now it is very late. Okay, so you cannot go back and read the textbook now. So try to solve most of the questions. Okay, இந்த மாதிரி இம்பார்ட்டன்ட் பாயிண்ட்ஸ் இல்லை சார்ட்ஸ் மாதிரி ஏதாவது உங்களோட ப்ரிப்பரேட்டரி புக்ஸில் இருந்துச்சுன்னா டெஃபினெட்லி கோ த்ரூ ஆல் தட். ட்ரை டு ரிமெம்பர், பிகாஸ் மெனி ஆஃப் த ஃபேக்ட்ஸ் யூ ஹாவ் டு மெமரைஸ் அண்ட் ரிமெம்பர். தட் இஸ் த ஒன்லி சாய்ஸ் யூ ஹேவ். ஓகே, another slide that you can take a screenshot of. Okay, so try to remember all these syndromes, what are the important oral manifestations of these syndromes, etc. Only that will help you in your correctly identifying the correct choice, because this is a late time. Okay, if it was much earlier, 6 months before you prepare panna aarambichirundinga, probably you could have started from the textbook and then gone to the MCQ solving part. Okay, another slide that you can take a screenshot of. Please take a screenshot of all these slides. Go through them at your leisure. Okay, anytime you have any questions, probably you can try to contact me. Probably you can send your messages to Dr. Vinola also, and she can forward me the questions also. Okay, so that finishes the oral pathology revision. It was fast, I know it was fast. I hope I have done justice to it, and I hope all of you have benefited at least to some extent from this small 3-hour session. Okay. Thank you all. Wish you all the best.